Good evening, everyone, and welcome to our information and support session. My name is Kathleen Helgeson, and I'm the coordinator of the Patient and Family Resource Center. And we're very pleased to offer this session tonight in partnership with Lung Cancer Canada and the generous funding support of the CancerCare Manitoba Foundation. So just a quick housekeeping note I should mention is, besides helping yourselves to food, which I hope you'll do at our break, the bathrooms are just out this door and to the left. Okay, I'm going to turn things over to Michelle, who will be your moderator for this evening.
Hello, everyone. I have to remember not to wave because my camera will start following me. Anyway, welcome to everyone. I'm the coordinator of patient support initiatives at Lung Cancer Canada. And I'd like to start by acknowledging that we are meeting from all regions of Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Red River Métis. It's important for us to foster inclusion and reconciliation, and we encourage others to do the same. I would like to thank Kathleen Helgeson and CancerCare Manitoba for partnering with us to bring this event to fruition, and all of the speakers here this evening for joining us and sharing valued information and resources. Lung cancer is too often a forgotten cancer, even though it is the most commonly diagnosed. We at Lung Cancer Canada work to support persons living with lung cancer, their care partners, and families with support services, education, and resources. Our mission is to educate, advocate, and support the lung cancer community. With that said, I'd like to introduce our first two speakers. Jay McCormack is a psychosocial oncology clinician with a master's in education from the University of Manitoba. He provides counseling to individuals and groups at CancerCare Manitoba with a focus on patient-centered support through holistic, inclusive, and anti-oppressive care. Amanda Chou is a registered social worker with Manitoba College of Social Workers and a member of the Canadian Association of Social Workers. She offers specialized counseling to both patients and their families. She is instrumental in organizing and facilitating a range of support programs and that are tailored to meet the diverse needs of clients. Welcome. Project.
Okay, yeah. Hi, everyone. Welcome. Thank you for having us today. My name is Amanda. Yeah, one of the psychosocial oncology clinician. And this is my coworker, Jay.
Hi, I'm Jay. Very happy to be here and speak to you all. Okay. So we're going to talk about our supports in psychosocial oncology. What we're going to cover is the importance of addressing supportive care needs, the patient and family support services at CancerCare Manitoba, specifically psychosocial oncology, which is where we come from, and PSO or psychosocial oncology clinician or counselor if you prefer, and how we can come together. Okay. So the emotional impact of a cancer diagnosis, this is some of what, we see. And of course, recognizing that everyone is different. So a loss of predictability and control can come up. Thinking about those uncertainties and those unknowns, sitting with that and having support. Multiple changes, right? Changes to work, school, changes to self, to physical changes through treatment and symptoms, changes to routine, so many changes that can happen. Multiple losses. So thinking about like the loss of before, loss of self, figuring out what are some of the losses that come up around a diagnosis. And a wide range of feelings for the patient and the important others in their life. So what we'll talk about is what we do is support patients, but also their care network and how important that is to have support for everyone. So these are some of the stats around mental health and cancer. So 44% of people report anxiety, with 23% reporting significant anxiety. 15 to 25% experience major depression, 33% significant psychosocial distress, and that rises to 60% with advanced disease. The recent literature suggests that family members may have even greater levels of anxiety, depression, and psychosocial distress through a cancer diagnosis. So recognizing that distress is a normal part of this, that this is a human response. This can peak during times of transition, right? So again, those uncertainties, those unknowns, waiting, right? The waiting time. At least a third of patients and caregivers experience clinically significant distress that may temporarily disrupt function, right? So again, thinking of that disruption to the normal, right? And what that can mean. And the other piece is that this is highly treatable. So there are many ways, many individual ways to lessen distress and learn to cope with it. So what coping can look like? One of the first things is awareness of feelings and abilities, right? Really honing in on what am I feeling and what can I do? Taking control of the things you can. That's something that comes up so often, is asking the question, what can and can't I control in this, and recognizing. Having open communication, right? So that includes with people in one's network and family, also open communication with the medical team, right? Who can I call when I have a question? Those are things that can come up. And this ability to experience feelings related to illness without persistent anxiety or depression. Feeling distress, again, coming back to that last slide, is a normal part of this. So how can we really be honest with those feelings, with having those, while recognizing where something, anxiety or depression, isn't taking over and getting in the way of being able to clearly recognize the feelings. Oh, sorry. So why psychosocial support can be important. Anchoring in the storm. We can't take the storm away or make it stop happening, but we can maybe be an anchor in the storm and recognize one's own anchors in the storm. Space to share and be heard, right? Freedom to express what you need to without filter, without feeling the need to censor oneself, right? So that can be sometimes we're just a place to vent, and that's okay. Sometimes you need that. We could be a points person to check in with you on your journey. That includes, again, that question, like, who do I call when I have a question? That could be something, I need to get to an appointment, right? I need a taxi slip. That may be the role we have. And connection, so we can help connect to community resources and practical needs, right? So Amanda's going to talk a little bit more about all the bits and pieces, but that's some of what we support in our psychosocial.
Exactly. Thank you, Jay. And we are so excited to let you know about our psychosocial oncology program. So actually, we have our big team with 13 counselors in the city and 9 counselors in the rural area. So we all overseen by the Chief of Clinical Operation, Ken, and the Director of Patient Experience, Patty, and the Program Manager of Patient Family Support Service, Lorena, and our lovely clinical lead, Cheryl. So we all work together to provide a comprehensive support to support our clients and their family. So our program actually offers helpful resources through Patient Family Resource Center, as well as the Guidance Angel Care Room and the Breast and Gynae Center of Hope. We also hold some educational events like today, and we have our specialized dietitian and physiotherapist to cater to the specific needs to our client to enhance their journey at CancerCare. So actually, another very important part of our program is providing counseling. So our counseling service not just for our patient, but for their family and the children. We extend our service to all the age group, including pediatrics and adolescent. So we have our new AYA program, which support clients who age under 39. We also have different support groups like Coping with Cancer group, and very popular one is Lung Cancer Support Group. And we also have different programs to help our clients to move forward. So I believe here is the role of our clinician. So I believe every counselor actually playing a very important role in addressing the information needs. We ensure the client to access the accurate information by providing reliable resources and offer different types of support that the client may be benefit from, like some programs and groups. We also focus on psychosocial challenges, helping the client to cope with an emotional challenging associated with cancer, like feeling of fear, guilt, or managing their anger. We also help to support focus on social issue, helping our client with difficult social dimension of cancer. Like, for example, addressing the family issue, helping the client to communicate with the children, or helping the client to cope with the change in relationship. Maybe not just for the family member, maybe for the co-worker as well. So we also provide some financial and practical support, as well as the spiritual exploration as well. In our team, sometimes we will do some education and consultation to different team members, like nurses, in order to provide a well-rounded support system. So you may be interested, like if I'm really interested in your program, how can people get referred to it? So as a comprehensive outpatient service, actually client can refer themselves, or referral can be made by a healthcare provider with the client's consent. So here is our phone, like mainline phone number and the fax number. So if you guys are interested in our program, feel free to give us a call or reach out to your healthcare provider. And we are very happy to see, based on our program and our groups, we have 90 to 95% of a high satisfaction rates here. And most of our clients, like 25% of our clients, discover our program through Navigator newsletter. And here's some of the comments. Some of the clients said, my emotion recovery is harder than my physical recovery. And I wish I had known about the service earlier. Those comments actually highlights the importance and the necessity of our program. So I believe all of us, like in our team, believe that we can keep people from suffering, but we can help them to avoid suffering from the wrong reason, especially during their challenging time. So thank you so much for your attention today. Does anyone have any questions?
Maybe I'll put the phone number back up.
Yeah. Yeah.
So that's our main line there, the phone and the fax. Any questions? Yes.
How do you gain access to the newsletter?
Oh, great question. So through our services and through the Patient Family Resource Center, I'm sorry we don't have our email up here, but there is a way to email and be emailed the newsletter as well to join the mailing list. I wonder if anyone in the room has, is Kathleen here? Yeah.
Thank you.
That number is there, and they'll direct your inquiry to
Yeah, but there is a mailing list. Once you're on there, you'll get it every single month. It's a really great resource, and there's always like a new article and the list of groups and different things that are on. Yeah. Any other questions?
So I read that somebody said they wish they'd found you sooner. So I'm wondering, do you have, when somebody is newly diagnosed and they're coming into clinic, is there a form or a letter or process where they're handed the information right off the bat, so they are given the information? So should they choose to, search you out, that they then have it at that point, rather than trying to figure out it later? Like, is there a way that you can get it to the patient up front?
Yeah, so as I understand it, folks are often given a lot of things at the beginning, partially our information as well. As mentioned, was that something that can also happen is care providers can do referrals, and often do kind of notice like this might be something that they should connect with, And so it sort of happens. The other thing I really want to name and acknowledge is that sometimes that stack of stuff at the beginning, when you're trying to process everything at the beginning of a diagnosis, is a lot. So we try to do things throughout as well to keep connecting, because that's something that yeah, it can be just so much overwhelm at the beginning too. So that's an ongoing conversation with the medical team, is also kind of connecting with us as well. Yeah, great question. Yes.
When you are talking to newly diagnosed with lung cancer, are they mentioning about our, the lung cancer support group that's been so valuable to this group of people here? Because, I think sometimes people don't want a group, but sometimes that's a really important part. So I think it would be something for, because if I hadn't brought it up, I don't know that I would have been told.
Yeah.
Absolutely.
Yeah, and personally, because I'm responsible for us like the SG, so most of my session actually I did mention about the group to let them know, and I know most of the client are very excited for the group. So yeah, and then I hope this helped your questions. Yeah.
Yeah, and I think that piece of continuing to have the conversation, like you say, sometimes there's hesitancy about like, what's a group going to be like, but oftentimes when people have been in a group, that's exactly what it is I'm so glad that I went.
And just to mention, it's by Zoom and has been since COVID.
Yes, absolutely. Yeah,
They're very
thank you.
happy with that.
And Amanda,
Yeah.
you should join us sometimes, and we know what you're talking about when we come up with that.
Thank you for inviting me. Yeah, I will. Thank you.
Thank you very much.
Thank you very much.
Yes, and I was going to print out flyers for everyone here today about the support group, but I will email everyone and the online viewers how to, when you're like information on your support group, because it has helped so many. So our next speaker is Audra Kolesar. Audra is the manager of the Medical Assistance in Dying Manitoba Ostomy Program and the TIC Collaborative Care Services. Thank you. Thank you.
Okay. Yep. Okay, so I'm here today to talk about medical assistance in dying, MAID. You will often hear it being referred to as. Just to start, an acknowledgement, health services across Manitoba are provided in facilities located on the lands of First Nation Inuit and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nation treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit and Métis peoples in the spirit of reconciliation. So I like to start by defining MAID. So MAID is a situation where a person seeks and, if eligible, obtains medical help to help end their life. Some important words: a patient seeks. A person must want this. No one else can have MAID for someone else. A power of attorney, a decision maker cannot make a decision for another person. Only the individual can decide if MAID is for them. If eligible, you have to meet the eligibility criteria laid out in the Criminal Code of Canada, which I'll go over, in order to have MAID. So we are not death by demand. There's legal criteria that has to be met in order to qualify. This is a medical service. We are part of the public health services Shared Health provides Manitobans. And the end goal for us is to assist someone with death. MAID came into Canada through court challenges. So in 2015, the Supreme Court of Canada made a decision that restricting access to medical assistance in dying was unconstitutional. They gave Health Canada time to create laws around it. Those laws came out in June 2016, and that was the first law, Bill C-14. Sometimes I mix up my numbers. And it was focused on people who have a naturally foreseeable, reasonable death. So they were already on a path towards dying. There was immediate court challenges once that came out. And in 2021, a new law, Bill C7, replaced that, and they created 2 tracks for people, which we'll go through. There was some other changes as well, which we can go through. In 2021, they put a ban on people requesting MAID who have a mental disorder as their sole reason for wanting MAID. It was supposed to come into law in 2023. It was delayed a year, and it's been further delayed till 2027. So currently, if you have a mental disorder and that's the sole reason for wanting MAID, it is not a legal criteria. Okay. So we offer 2 forms of MAID in Manitoba. Clinician assisted, where a MAID provider, who is either a physician or a nurse practitioner, will administer IV medications. There is a self-administered option by law. We don't normally offer that. There's a lot of complications with that method. It's a large amount to drink. You have to drink it all. Sometimes it's a very prolonged death. So we prefer the clinician assisted. It's very predictable, and we'll talk about what that looks like. In Manitoba, we have an interdisciplinary team that provides MAID services to everyone in Manitoba. So we go everywhere. We go to where the patient is, in their home facility, every corner of the province. We have physicians, a nurse practitioner just started with us, nurses, social workers, administration, and then we'll pull in other expertise as we needed, depending on the patient. So it could be spiritual care, could be psychology, speech language pathology. It really depends on that individual situation. The eligibility criteria. So this is from the Criminal Code of Canada. You have to be eligible for government funded healthcare in Canada. So you can't just come to Canada to have a medically assisted death. There are countries where you can, but not in Canada. You need to be eligible for government funded healthcare. You have to be an adult, which is defined as 18 years of age, and you have to be capable of making your own medical decisions. You have to have a grievous and irremediable medical condition. We'll talk about that next, because that is not language you're going to hear every day. This has to be a voluntary request, not the result of pressure. So we spend time alone with every individual we assess to really make sure this is coming from them. They're not feeling pressured to make this decision. And this has to be an informed consent to wanting help to die after reviewing all possible treatment options, specifically including palliative care. That is the only option specifically outlined in the law. We get a large percent of our patients are involved with palliative care. So 80% of patients who have MAID are involved with palliative care already. You don't have to, but we do have to talk about palliative care. Okay, so grievous and irremediable. You have to have all 3 things for your condition, disease, or disability to be considered grievous and irremediable. It has to be serious and incurable. A diagnosed serious and incurable disease, illness, or disability. You have to be in an advanced state of irreversible decline in capability. So self-care, not being able to do what you've normally been able to do. You don't have to be completely bedridden, but there has to be an advanced state of decline. And you have to have intolerable suffering that is caused by either your incurable or serious illness or your advanced state of decline, or both, and cannot be relieved under conditions that are acceptable to you. So there's lots of stories in the newspaper, right? So if the intolerable suffering is not being caused by anything, if it's being caused by something other than the serious and incurable disease or your advanced state of decline, you will not qualify for MAID. Poverty is very hard. There's lots of intolerable suffering that comes with it, but it would not qualify you for MAID. So currently in our law, no one under the age of 18 will qualify for MAID. MAID cannot be used as an advance directive. You must have all the eligibility criteria in real time. People get very confused around this. They want to lay out with their lawyer or whoever, if this happens, I want medical assistance in dying. That is not legal at this time. There are movements at the national level to look at that and include it, but currently it is not. So you have to be, it has to be in real time. You have a diagnosis, you have intolerable suffering, you are in an advanced state of decline. And as I said, whoops, sorry, that didn't go ahead there. Okay, and mental illness as the sole medical condition is also not allowed. This does not include neurocognitive disorders like Alzheimer's, dementia. Those can currently qualify. Some people get confused about that too. Often, when you have an incurable illness or advanced state of decline and intolerable suffering, you could have a mental illness or disorder along with that. And that's okay. That's expected. What we need to understand is what is driving your request for MAID. Do you want to die because of that mental illness that's also happening? Or is it that physical state that's driving it? So we talked a little bit about this. So in 2021, we created 2 tracks through the law. So track 1, that's what we call, because it's reasonably foreseeable natural death. Those are people who are on a pathway towards death. Track 2, there isn't a reasonably foreseeable natural death. So that's most likely a chronic disease that's not fatal. So the disease itself isn't going to cause the death, but it's incurable. The person is in advanced state of decline and has intolerable suffering associated with it. So an example would be something like Crohn's disease, let's say. That might be an example. So for track 1, incurable cancer would be on that track, something like ALS, where we know that that disease will end in death. There are also safeguards built into the law to make sure this is done properly. So there has to be a written request with a witness who will not benefit from the death of a person. There's 2 assessments, and they can only be performed by a physician or a nurse practitioner. The person must be informed they can withdraw their request at any time in the MAID process, including up and until the medications have been delivered. And at the moment, so at the dawn, the day of the death, we always have time alone with the person, and we ask them right then and there, do you want help to die today? And they have to give consent right before. And so you can withdraw at any time. For the track 2 folks, it's a little bit more complicated because their disease processes are usually more complicated. We have to consult with an expert in their condition. We have to look out, it's a little bit more closer look in terms of any unmet needs. And there has to be agreement between the MAID assessors and the patient that they've given serious consideration to all options to relieve their suffering. Canada is the only country where you don't have to try all options, but you have to give them serious consideration. This is our process. So we start with intake. You can do a self-referral, or a healthcare provider can refer you. Then a nurse will triage you over the phone, get a sense of what's going on with you, pull your records and charts. And then you'll have 2 assessments. They usually are on different dates, but they can occur at the same time. You need that written request that is required by law. And then our terminology for the day of the death is provision. So then that's that end of our process. We are not an emergency service. As you can see, it's a complex process. We can't normally rush through it, and we want to make sure we are doing the right thing. So it's a 2 to 4 weeks, usually for track 1 folks. Track 2 can be as long as there's a minimum 90-day waiting period. So there needs to be thought in terms of when, if this is something someone wants to choose, we usually can't rush through that process. There's big consequences, right? So we want to make sure we're doing it right. I always think it's important to talk about what the day of the death looks like. So we start 2 IVs. We give 3 different IV medications. It takes about 5 to 10 minutes for those medications to work. We schedule 2 hours for provision. We do banker's hours Monday to Friday, 8 to 4. We cannot offer time outside of that, unfortunately, but we do travel across the province. So we have gone to people's cottages if that's their choice. We really do our best to honor what that patient wants that day to look like. Some people have ceremony around it. Some people have their whole community come out and support them, or their family. There may be songs. We try very hard to respect that day. Some people don't want anything. So we really want to talk to a person, say, what does this mean to you? Is there something that you want to have on that day? We do our very best. A MAID death is very peaceful and gentle. In fact, what people who are there to support that person during that time will see is a person falling asleep. So there's usually no jerking, there's no loss of their bowel during this time. The person falls asleep. It's very peaceful and gentle. For some of our healthcare providers, it's very different than what we normally see in a death. So usually it takes about 1 to 2 minutes for that person to fall asleep. They will stop breathing in 5 to 6 minutes, and then usually around 8 to 10 minute mark, their heart will stop. Some people will have a shorter time frame, some people have longer. It's really hard to know. Okay. Also in 2021, what happened was the idea that you have to give consent on the day of their death was challenged in court. So there was a woman named Audra. She had breast cancer with mets to her brain, and she knew because of the brain mets that she was at a high risk of losing the capacity to consent. She really wanted to have an assisted death. It was very important to her to choose how she was going to die. But she was concerned. She really wanted to have one more Christmas with her family, but she was concerned if she waited that long, she would lose the ability to consent. So they went to court and they won. I think it was unfortunately too late for Audra, but her family carried out her path once she had passed. So we now have in place what's called a waiver of final consent. And it's an agreement between the patient and the providers that on a specific day, if that's the day they want to have help to die, if they are unable to consent on that day, we can still go forward. There's some rules around this, as I'm sure you can imagine. The patient has to have been approved for MAID, and it's only for track 1 patients. So some people think, oh, maybe this is a type of advanced directive. It's not. You have to be approved for MAID. You have to choose a date that you want to die on. You have to be at risk of losing capacity. And so it's a written agreement between the MAID providers and the person that we can still go forward. Now, in the law, there's wording for everybody, including if a waiver is in place, that if the person shows signs of refusal, we will not go forward. So this doesn't mean reacting to getting 2 IV pokes, because we all know you're going to react to that no matter what state you are in, because it's not nice. But this is more pushing us away, shaking their hands, saying no. If we see them as signs of refusal, we will walk away. That's embedded in the law. So our team is very fortunate that we have an interdisciplinary model. We were the first in Canada to operate in this manner. And so we have psychosocial specialists who are better known as social workers who are part of our team, and they offer an invaluable service to our patients as well as their loved ones. So they are able to provide services for people physically located in Manitoba. So some families also have loved ones living in other provinces. We can't necessarily support those folks because they have to be present in Manitoba, but we can help guide them to resources with where they are. We can only provide short-term support. We just aren't able to provide the long-term, but what we can do is help refer to longer-term services if they're needed. We also provide support for staff. So some healthcare providers have never been involved with a MAID. So we help them know what to expect and debrief afterwards if they need to. We also can provide services for patients who've been declined for MAID, because that can also have some impact on them as well. And we want to make sure they're supported. We do also have a plan to do a suicide assessment and safety planning if needed. MAID is not considered suicide by law. There is a difference, and our team can help navigate and move those people more to crisis response supports. So some of the things our social workers are able to do is connect people with resources. And there is some psychosocial support that's specific to MAID. So there is still stigma out there around MAID. And so we can help patients as well as their loved ones navigate through some of that. Sometimes we'll do a complete assessment for that folks, especially on track 2, to really understand what are their needs. Are there any unmet needs? What is driving this person to ask for help to die? We can refer out to other organizations and services for support. We do work closely with CancerCare as well. And we will check in with family and loved ones if they're identified by that patient after the death, just to make sure they're okay and offer our support. We can do some therapy, again, short term. We have offered grief support groups. Sometimes they're available, sometimes they're not. It depends on if people want them. So we run them, and if we don't get enough people, then we'll move them out, or sometimes we have too many. So that is also something we have done. Just some other things to know about MAID. There's no cost. So this is part of the public health. Insurance and CPP is not impacted. We get that question a lot. So people are concerned about that. This is not considered suicide by law. So these are not impacted. People do not have to tell their family or involve their family. So this is about the person and their choices. As healthcare professionals, we have to respect those boundaries. If patients say, I don't want these people to know, we have to respect that. It can be challenging. Our social workers will often work with them to work through that and help maybe build some bridges or do some grief therapy with them around not having the supports there. But it's important for folks to know that, so patients have that choice and autonomy. And family cannot make the decision for someone. So if you're a power of attorney, you can't decide this person wants MAID. And it's hard because some folks, especially with those neurocognitive disorders like Alzheimer's and dementia, they've talked about it and now they're not able to consent. And as a family member, I know they talked about this for years. I know this is what they want, but I cannot make that decision for that person. And those are really challenging. But they also can't say no. So if there's a waiver in place, a family can't say, no, we're not doing this. If that's the agreement with that person, we will go forward. My final point, and then I have a little bit of stats to show you. And this is kind of what I want you to remember the most. So that's why it's at the last. People will decide to choose MAID despite optimal care. This is about autonomy and choice for them. So in Canada, if we start in 2016, when it first became legal, this is till 2022. So these are federal stats. They're a little bit behind. They haven't released 2023 yet. You can see the number of MAID deaths have increased annually. The two small red bars, that's the track 2 folks. So they're a very small percentage. So all the people in Canada who died, 13,000 in 2022 had MAID deaths. Generally speaking, it's about 4% of all deaths across Canada. We do see a smaller amount, more males than females. Those were the only 2 genders collected. We don't know why. We're still trying to figure out why that would be. The average age is 77. But we have seen people all the way from 18 to over 100. So as you can see, cancer, which is on the left-hand side, is by far the biggest population of folks who ask for a MAID. And then cardiovascular, other conditions, so that would be like ALS, those kind of diseases, respiratory, etc. So it's a very high percentage. This is a breakdown of cancer types of people who request MAID. Lung cancer is a high percentage, colorectal, etc. And then there's also the other cancers in the bottom. The nature of suffering, loss of ability to engage in meaningful life activities is by far the biggest. What we hear, along with a loss of being able to form activities of daily living. So being able to care for yourself. That's what people are describing their intolerable suffering. This is across Canada. So Manitoba is right here. So when we look at the percentage of MAID deaths, we see the highest percentage in Quebec, which is where the court cases come from. So the first court case in 2016 came from Quebec, and we've seen other court cases in Quebec. And then British Columbia also has a high percentage. We don't know exactly why. There's lots of work going on trying to understand the reasons behind this better. But we're in the bottom 3. So currently about 2% of all deaths in Manitoba are related to MAID. It's a small percentage. It has grown every year since MAID became legal. And then the other provinces kind of lie in between. This is our information to contact us, and all this information is also on our website. Anybody have any questions? Yeah.
Not getting the timeline on when you get the sheet filled out, so that MAID is in place, like you've done your 2 interviews. At what point do you decide to go fill out the paperwork?
Like the written request?
Yeah.
So what we do is usually on the first or second assessment, we'll bring it with us and help people fill it out. So it's just a legal document saying that it's required by law that you have to sign. And we have a pre-printed out form that we use. People have sent them in first, but what the written request says is that I have intolerable suffering. I have an advanced state of decline, and you agree to them. And some people don't necessarily understand what they're actually agreeing to. So once we've done the assessment and talked to people about what MAID is and if they're eligible, sometimes they've actually said, you know what, I didn't know that, so I'm going to redo it. So we usually do them after during the assessment, so people have a really good idea of what they're agreeing to.
So, but you can't do it too far in advance.
You have to have the condition, you have to currently have all of it. Yeah. Yeah. And that's tricky for people with dementia, right? Because usually when they're in their point where it's intolerable suffering, they've lost that capacity to make medical decisions. And so it's a timing issue. It's a hard decision to make, right? And I mean, if you asked every single one of our patients, when we ask them, what would change your mind? They're like, cure me. I don't want to suffer. And then I would change my mind. So I would say all of our patients don't actually want to die, but this is where they are.
So it's more towards the end of life before the paperwork gets done.
Yeah.
Right.
Yeah.
So we need to expand on that. In Manitoba, in people who choose medical assistance in dying, do you know what the typical amount of time is between initial contact with the MAID program and their final day?
It's a good question. I don't have numbers, so I'm gonna tell you what I think.
If you can.
We see 2 groups of people. We see people who are really actively dying. They're suffering. Palliative care is doing absolutely everything they can. It's just not enough for them. And it's a tight turnaround. So it's that 2-week window. we see people who aren't quite there yet. And so they're like, probably, really where we talk to people around within the next 3 months, are you thinking? If someone says, I'm looking at a year or more, we'll say, call us back when you're closer to that time. So it's around 3 months where we look and say, that's kind of the window where we're looking at. Because then we cross into an advanced directive type situation. And intolerable suffering for a year is not a good plan. That's hard. Yep.
At this point, if things are not that, is it about, when you mention it to your general physician so that he's aware of it, so there's something on the file in case there is dementia, or is that?
No, and I know there's a big group of people who really want this to be set up in advance. And there's lobbying going on right now at a federal level to have, and they are looking at that as an option. It's tricky. I mean, no, it's not legal right now, but you know, it doesn't mean you can't set it up. It's not legal right now. And until it becomes legal, those documents wouldn't count. And in fact, I think, you know, as someone who does this work, I can't imagine unless there's a video of someone telling me this is what they want. It would be really hard as a practitioner to just look at a piece of paper and make that decision. So there's going to have to be a lot of work done to make it make sense. Yeah.
Could you set it up, say before you had the dementia, and say if the type of disease you have causes brain mets, and then cancel it if you're not there yet? Do you know what I mean? And then like kind of like it's like a paper process until
Like a pre-approval. So I don't know if everyone heard, but the questions about pre-approving. So no,
no, you can't.
You
You
have-
can't kind of cancel like, okay, that was my date. I'm going to or cancer. Cancel it. You know, it hasn't metastasized to my brain yet, and we'll just
yeah, you can always cancel.
Yeah.
You can change.
But
it
I
on
meant just
any
use
time.
that as a way of gaining time to, if that was something. That might be how. that's
Yeah, because you still have to have that advanced state of decline
it. Okay.
and that
Okay.
intolerable suffering. And usually, if you're at that point, those things aren't there.
Okay.
Yeah, but yeah, I know you're trying to think of a workaround.
Yeah, sorry.
Good try.
You're not the first to ask that question.
So what cognitive level, like, I guess, does there have to be other checks that are done to say this person has a dementia and can't make that decision versus someone that
So we
makes that?
So we usually assess for capacity. And it's a conversation, right? So we always talk with the patient and we have ways of asking them if they understand what we're talking about. So there is some flexion, like it's not a simple answer. If we're not sure, then we would consult with a psychiatrist to also put an in, like, what do you say? Do they have the ability to consent? There are some hard and fast rules. So if you are under the trustee of Manitoba, you cannot have me. Because you have now, all your decisions are in the government's hands and the government cannot choose to have someone die. So that's the only hard and fast rule. But there are folks who, you know, if you come between this time and this time, they're much brighter and alert. And so we go at that time and yes, they have the capacity, but you know, 2 hours later, they may not. But so there is some fluctuation there, but yeah, we usually do our own assessment of that. There isn't a standard tool. Any other questions?
Yes, maybe a little far-fetched, but let's say a guy's, he's suffering. He's going through the process and he's just about 90% approved by MAID, and he goes into remission. Now what do you do?
I think that would be a very good thing for that person.
So you start all over again?
I guess it depends.
Because
So
he or she was really adamant about using MAID.
yeah. Well, we're never going to force anyone to have MAID. Absolutely. And I think it really depends. So what we have done is we've had people who were approved and things changed, because that happens. And then they phone us in 6 months and they're like, actually, things got better, but now things aren't. So we'll just do a check-in with them, a reassessment to see, okay, what's changed? Do you still meet qualifications? Because we know people's health changes, right?
So at that point, would you kind of like close the file and then, let's say if things start up again in the next 2 or 3 months, you gotta start all over again?
Not necessarily. If we've started, we probably check in and just talk to that person or get their chart and say, hey, what's happened? Not necessarily. We don't want to make the process a burden. It's a big process. We know that. And we know people are suffering. But we have an obligation to follow the Criminal Code of Canada, right? So
You mentioned it was like a 2 or 3 month process.
2 to 4 weeks.
Oh, that's not bad.
Yeah, for track 1. For
Okay.
track 2, it's longer, 90 days. But yeah, and that's just to make sure, because you have to have a diagnosis. We need to see that diagnosis. We need to talk to the person around what treatment options have been offered, what if they've tried them all, if not, why. So it's 2 to 4 weeks. Yeah.
Lots of questions at that point. Sure.
Yeah. We try to be very patient-centered, right? And really, we don't want to be a burden and cause more suffering. But we do have there's big consequences if we don't do our job right, both for the patient, but also for us.
So everything's on a case by case basis.
We have a standard process, but there's lots of people have complex lives, right? So there's lots of things that come into play, and we look at every person as an individual, for sure. Yeah.
Unfortunately, we've run out of time
I
for
know.
questions. I'm sorry.
That's okay.
If anybody does have any questions that weren't answered today, you can email myself at info@lungcancercanada, and I'll make sure that those questions get answered. So our next speaker is Dr. James Browse. He is originally from Winnipeg and completed a subspecialty training at the University of British Columbia, BC Cancer in Vancouver. He's the medical lead for CancerCare Manitoba, for the CancerCare Manitoba Lung Cancer Screening Program, and an active member of the Thoracic Disease Site Group at CancerCare Manitoba. He also serves as the Director of Bronchoscopy at the Health Sciences Center, helping to educate staff, improve service delivery, and direct priorities for investment, including new bronchoscopy technology. His interests include lung cancer screening, advanced bronchoscopy, peripheral pulmonary nodule biopsy techniques, pleural disease, and optimization of lung cancer diagnostic pathways. Thank you, Dr. Brooks.
Thanks. Can everyone hear me okay? Right. So I'm very happy to talk to you guys a little bit about our plans for lung cancer screening in Manitoba. It's unfortunately not running yet, but it doesn't mean that we've been doing absolutely nothing for the last few years. So we have a big team hard at work on trying to, make sure we're ready to hit the ground running as soon as we get the go ahead. So I wanted to spend a little bit of time just talking about how lung cancer screening is going in Canada altogether, just for some context. And then we'll talk a little bit about how we intend to set up the program and where we're at exactly in the process. So this chart is from the Canadian Partnership Against Cancer, and it shows the state of development of lung cancer screening across the country. So as you can see, in blue, we have 3 fully implemented programs, with Ontario's having a little bit of an asterisk beside it. So Nova Scotia and British Columbia are fully operational. Nova Scotia is the most recent one to be fully running. Ontario is running at 4 hospitals in the province. So they call it a fully operational program, but they still need to expand it to the rest of the province. There are large-scale pilot programs going on in Quebec and in Alberta that are multiple thousands of patients over a few years. And then they're going to essentially take the feedback and learning from that to fund and fully implement their programs once they complete those pilots. There are a couple of provinces that are still in the planning stages, and then there are a few in pink that have funding confirmed. We did receive confirmation of funding late last year, although now there is kind of a mandatory review of all major capital healthcare expenditures going on. So we're on a little bit of a pause for the moment. So let's get into the program structure and how it's going to work. So every lung cancer screening program has multiple different components to it. So I'm going to go through each one of these individually. So lung cancer screening is a little bit unique as a screening program in that, like for breast or colon or cervix, we're targeting an average risk population. So we can just mail a letter to everybody who meets the certain criteria and get them to sign up for the program. But for lung cancer screening, we have to target a high risk population because otherwise we would be completely overrun with false positive results on the CT scans. So we have to come up with methods for targeting that high risk population. So we expect that the majority of the referrals will come from healthcare providers because those are the people that know their patients best. They're going to know who's high risk. They're going to know their history. So they're going to be able to refer people. But we also know that access to primary care is a challenge in Manitoba and in all of Canada. So we plan to have a self-referral pathway as well. And we intend to get in touch with those people by advertising campaigns. People know their history and they know, if they fit the demographics. So initially at the start of the program, we plan to target this age group 55 to 74, and we want people to have had a smoking history that's daily for 20 years. It doesn't have to be consecutive, and we don't put a certain amount of packs per day or anything on it like that. We just want people to get involved with the program and then come in for a more formalized personal risk assessment. And so that risk assessment is individual to the person. So what we do is we take a number of their factors, so their age, smoking exposure, education level, whether they have respiratory disease, their family history, and we put that into a well-validated calculator. And we try to come up with what is their risk of developing lung cancer over the next 6 years. And so if we reach a certain threshold, then those people will be eligible for screening. The nice thing about this is too, that as things go on and people get older, their risk can go up. So even if they don't qualify at one point in time, they may reach qualification at some later point in time. And the reason for doing this is that we end up having a higher cancer detection rate than in the lung cancer screening trials where they just use age and pack years, or like they do in the United States for lung cancer screening. So we don't have to screen as many people or do unnecessary CT scans on people that are not at high enough risk and potentially put them in harm's way, but still find as many cancers as possible. Every lung cancer screening program has to have smoking cessation built in because this is a real opportunity to get people to stop smoking altogether if they haven't stopped already, which many people will have stopped already. We plan this to be an expansion of CancerCare's current smoking cessation program, but with an increase in staff, increase in resources. It's going to provide counseling sessions as well as free prescriptions for smoking cessation medications for anybody who participates. And then of course, there's the screening test itself. So we use a low-dose CT scan for screening, and there are two main sort of phases of screening. So the first is the baseline. That's the first CT scan that anybody gets. And that is going to identify prevalent nodules or cancer. So the ones that were there already. We don't know how long they've been growing and that kind of thing. And then we'll be able to and I'll get into this a little bit more, figure out somebody's individual risk based on their CT scan and assign them to a screening interval based on that. And then after the baseline, there will be follow-up screening rounds, and that's going to identify the new nodules that pop up, so new growths. These are going to be higher risk because they weren't there at the baseline, so by definition, they would be growing faster. So it's important to separate those out at the beginning. Now, we plan to use a risk score and apply that to people's CT findings. So if we find a nodule on the scan, then we use the patient's demographics as well as the characteristics of the nodule, like where it is, its size, what type it is, like what it looks like. And we assign a % chance that this nodule is cancer. So the majority of nodules are not cancer, but there's a certain small number that are. And being able to differentiate cancer from non-cancer is kind of the holy grail of lung cancer screening. So this is the best tool available to determine that risk now. And then we can assign people their screening interval based on their risk. So if they have no nodules or a very low risk, then they'll get a CT scan every 2 years. If they're low risk, but they're not the lowest possible, they'll get an annual CT, which is kind of the standard in other places. If they're intermediate risk or there's some findings you want to keep a close eye on, they'll get a 3-month CT scan. And if everything is okay, they'll drop down to one of the green zones. And then for very high risk findings, they get immediately sent for diagnostic referral. And I'll talk a little bit about that later. So basically, by using this risk calculation, we can reduce the number of CT scans and the radiation exposure for people who have very low risk findings. There's a lot of resources expended in other programs on very low risk findings, and it causes a lot of anxiety and doubt and all that kind of stuff. And those are important things that are intangible and sometimes difficult to quantify. So it's not only good from a resource utilization standpoint, but it also reassures the right people that their findings are not that high risk. And then for those red zone patients, they get a seamless transition to a diagnostic referral. So you don't have to go back to your family doctor and then the family doctor refers for a workup. Everything happens automatically. So a specialist triages based on the scans, and they schedule you for the most appropriate thing that you need. So either that's a clinic visit where they can arrange some follow-up scans to watch things closely, or directly to biopsy procedures or staging of lung cancer so we can go directly to treatment as quickly as possible. And of course, we want to involve CancerCare navigation during this phase 2 so that once everything is diagnosed, all the tests are finished, then navigation can make sure that they get to the right treatment clinic as quickly as possible. So where are we now? So as you can see, we've made the main sort of program decisions. We've drafted qualifications for the radiologists who are going to read the CT scans. We've got scripts and protocols drafted for all the screening navigators that are going to work with us. We've got education materials for primary care doctors so they know, and nurse practitioners so that they know who is going to be eligible or who should be referred to the program and how to talk to their patients about how the program works, and educational materials for patients or people that might participate. We've got smoking cessation materials, our nodule management protocol, and advertising. And we just recently finished renovations for the office staff at the Misericordia site so that everybody has a place to work as they're getting people through the program. There's a couple of big things that we're working on right now. So the biggest one that we're waiting for the go-ahead on is our major IT infrastructure components. So to run a program like this, we need a lung cancer screening registry. So that's going to be the heart of the program. It's going to track everybody, all their results, all their appointments, send out reminders. make sure that nobody gets lost to follow-up, and it's going to automatically help all of our screening navigators know what the next step is for each person. And then the other part is the radiology workstation software. So doing these calculations on the nodules and stuff like that needs computer assistance to be able to get the most accurate result and to track the progress of nodules on CT scans over time. Primary care attachment, like I mentioned before, is a big issue in Manitoba. We have, I think, the lowest rate of per capita family doctors in the country. And we know that lung cancers can disproportionately affect people who have barriers to accessing primary care. So we're working on setting up a pathway so that during this process, we can connect people with a primary care doctor, because we need that partnership to make this program a success. So we're going to help facilitate that piece so that the connection can be made in a timely fashion. And then we're also working on this central triage process, which again is going to depend a little bit on some of the IT infrastructure to make sure that that all happens smoothly. And then we still have lots to do. So once we get our go ahead, then there's going to be a lot of detailed work on all the workflows for each person that's involved with the program, all the clerks, the navigators, radiologists, everybody. We need some training materials for some of the specialists that are going to be involved so we can onboard people as the volume grows over time. And then quality assurance is a big part of making a program like this a success. So we have on a national level, we're discussing quality indicators that we're going to be tracking over time. And we're going to have a multidisciplinary team that's going to review cases that, you know, are difficult or fall outside of the norm, or just, you know, doing a check-in on a certain percentage of cases just to make sure that we're meeting the standard that we set out for ourselves. And then, of course, we have to hire everybody and all that kind of stuff. So there's a lot of work to do, but we're kind of at the stage now where we're just ready to hit the ground running and go. So that's a quick sort of rundown of what we're planning. I'm happy to take any questions. Yeah.
Are you aware of any research that's being done for people who have cancer, lung cancer, but have never smoked?
Yeah, so it's an interesting area of research. There was, it's a nascent area of research, and we don't have any sort of very definitive guidelines for incorporating those people into lung cancer screening. But the biggest study that's been done on this is called the Talent study that was done in Taiwan. So in Asian countries, there's a very high rate of lung cancer in non-smoking populations. So we don't know exactly why that is, if it's genetic, environmental, or some combination of those things. But they've done a screening study that looked at particularly, you know, family history among sort of the other typical risk factors, and used that to recruit non-smoking people into lung cancer screening. And they did, some of those results are still kind of immature, like we don't have the decade of follow-up that we have for all the other studies that have been published so far. But their results are intriguing. They do show reductions in mortality. Is that generalizable to a North American population? Hard to say. Like if we could develop a risk model that we could incorporate into our own, then I think that would be helpful. And then there's also the question of overdiagnosis. So with a lot of those patients, some of them were older and had very indolent cancers that might not have ever affected their lifespan. So that's still an outstanding question in those particular studies.
Since Canada has one of the highest radon rates in the world, could not one of your screening criteria be if someone had a radon home mitigation as being one of the things that enables them to have a screening test, because radon isn't addressed and Manitoba is one of the top in Canada?
Yeah, I agree. It's a hard thing. It's a hard thing to quantify. So it's another area where the research is kind of lacking. So it's hard for us to put a number, and it's hard for us to measure in people's homes and stuff, because not everybody's exposure is going to be uniform. Like if nobody had radon mitigation and you could somehow model the risk into the population, then you could probably incorporate it. But as far as I'm aware, that research hasn't been done. And when we look at sort of the attributable risk of radon compared to tobacco smoke, it's like 100 to 1, like it's not even close. It's
Actually, that's from what I've read about radon and.
it's not that it doesn't cause lung cancer.
It is the second leading cause.
Yes, but it's very far below cigarette smoke. It's not to say that it's not an important risk, but it's more difficult to quantify.
I've been reading that there's research going on for a blood test for lung cancer detection. Do you know where that is at in the research? And obviously that will be a game changer for the non-smokers. If it's a blood test versus the CT scan.
Yeah. There's a lot of stuff being done on blood tests currently in sort of like higher risk or metastatic settings and things like that. I think that's probably getting closer to prime time for very early types of detection like this. I think it's going to be quite insensitive. The area that's actually been, in my mind, more interesting in terms of detecting early lung cancers is exhaled breath analysis. So that's something that's very new. So, you know, it's, again, we're still kind of years out, but they can measure different organic compounds in your breath and, you know, compare that to sort of a normal value and then see if that is associated with cancer. So it's all very early stage stuff, but I think that is more likely to be incorporated into our risk models. Like I can foresee that, you know, we would calculate your risk, send you for an exhaled breath analysis, and then depending on that result, that would either shoot you up or shoot you down in terms of your overall risk of developing cancer.
Not everyone might meet the criteria of your risk assessment.
Right,
You
but
know, even-
but that might be an important modifier.
Yeah.
And again, these are always kind of, all these criteria are being researched constantly. So we're trying to design the program in such a way that we can incorporate new research as it becomes available and modify our risk scores as we need to, and make sure that we can address as much of the population as we can, but while still using our resources appropriately.
What kind of time frame between now and the actual start of the project?
I wish I had a clear answer for you on that.
You need money.
Follow the MP.
Yeah, exactly. Speak to your local MLA.
I'm just wondering about the cost benefit of catching these early when compared to someone who ends up, and we can catch it early, we can do surgery, we don't have to go on. So, you know, if they looked at the cost benefit of the screening, even though it costs a lot to do it, not just people's lives are saved, but in the long run, you're saving hundreds of thousands of dollars per person. If you can.
Agreed.
So,
Very much agreed. It's a complete no-brainer from a cost effectiveness standpoint. Like, yes, when you look at it as a line item in a budget, it looks expensive. But when we look at, like, we've modeled, you know, how our program would run in Manitoba, and we look at, you know, how many dollars per quality adjusted life year we would get. So that's sort of a standard measure. And it ends up being around like 30 to 33,000. And usually any sort of public payer is looking for a threshold of about, you know, 50,000 is considered like a good value intervention. So we're well below that. So it's just, we've made the business case, that's all been kind of submitted and everything. Like I said, we're kind of on pause, but I fully expect that this will move forward in the near future. I wish I could give you a date. I would love to throw up like a launch party date on here, but unfortunately I can't. Yeah, exactly.
I'll bring them here.
We're well over time.
Okay.
We can take one more question. We're quite over time.
Okay, this registry has got me really intrigued. Where's the data come from? Is it supplied by existing hospitals or whatever? And At what point in time are you gonna have qualified staff to analyze this registry? Because I see that as a huge tool.
Yeah, exactly. So we want to design the analysis from the start. So we're going to have analytics built into the system from the very beginning, and CancerCare has a robust staff of data analysis personnel that can help out with that. And we'll have sort of regular reviews of that. For the registry, a lot of the data that we're going to be bringing in is program specific. So it'll be inputted by the navigators, but we have plans to have connections with, obviously like just our demographic databases and stuff like that, but our radiology systems, our lab systems, et cetera, are all planned for integration as well.
So is this something that you gotta talk to Mr. Wabi about, get going, or what do we do here?
Something like that.
Yeah.
Okay, thank you.
Thank you so much, Dr. Brass. So I do want to give everybody time to thank you, everybody, for returning on time. I am happy to introduce Dr. Joel Pearson. He pursued postdoctoral training at the Lunenfeld Tannenbaum Research Institute in Toronto, where his work involves studying neuro and neuroendocrine cancers, such as small cell lung cancer. He's recently recruited to CancerCare Manitoba and the University of Manitoba in September 2022. There, his research focuses on the underlying biology of small cell lung cancer, with the goal of using these discoveries to identify new treatments for small cell lung cancer that will improve patient outcomes.
So thank you for that intro, and I hope everybody can hear me. So, okay, so yeah, my talk's a little different than some of the other ones, but I hope everybody still finds it interesting and informative. So I'm going to be talking about some of the research that my lab does here at CancerCare, I guess a couple floors above us. Well, I think I moved around. Well, looks okay. But, so I'm going to tell everybody a little bit about myself before I get into what I actually do. So I'm a really small town boy. So I'm from this remote island off the coast of BC, where I was born and raised in a town of about 1,000 people. Pardon? Yeah.
Oh, nice.
My daughter was just there.
Oh, okay. It's a fantastic place. I go back every once in a while. It's really great. And so after really spending my entire life there, I moved to the interior of BC to do a Bachelor of Science degree. And from there, I spent a little bit of time on Vancouver Island to start graduate school, and then moved to Edmonton to complete my PhD. From there, I jumped over to Toronto, and I was there for way too long doing postdoctoral training. And then more recently, I moved to Winnipeg about a year and a half ago to start my own research lab. And so my research background, things have moved around a little bit, I apologize, that's okay, is as a molecular biologist. And so what I kind of jokingly tell people sometimes is I study things that we can't actually see. So if we can see it, it's not what I study. Now that's obviously a massive oversimplification and not really true. But what I really study is kind of the underlying cause of disease, such as cancer. And so what's happening at that molecular and cellular level that's gone wrong, that's different from a normal cell that gives rise to cancer, for example. And so really the goal of this is to, by a better understanding the underlying biology of the disease, we hope that we can identify kind of better ways of treating it that are really targeted at what's happened, what's gone wrong to cause this disease. And so for my training, my focus has really been on cancer. So in my PhD, I studied blood cancers, and then in my postdoc, this moved to a variety of different cancers, such as small cell lung cancer, retinoblastoma, which is an eye cancer, And since starting my own lab, the focus has really been on small cell lung cancer, which is where really my research focus is at. And so, we really broadly classify lung cancer into two main groups anyways. It's either small cell lung cancer or non-small cell lung cancer. And then within the non-small cell lung cancer group, we have, we subdivide that into different types, such as adenocarcinomas and squamous cell carcinomas. But my research really focuses on this top group, small cell lung cancer. And I think why I got interested in studying this is that the discoveries from a research point of view have really lagged behind in small cell lung cancer, and that's really impacted treatments for patients. So I don't want to get into a lot of details here, but really the way that small cell lung cancer is treated hasn't changed much in 40 years. It's still really based on the standard chemotherapy regimen. And the one thing I really want to highlight on the bottom there is there's been no advances to develop kind of what we would call like next generation targeted therapies that are really targeted at the underlying biology of the tumor. And this, contrasts somewhat in non-small cell lung cancer, where we've been able to understand the underlying causes, the underlying biology more, and that's led to, some new treatments at least for subsets of patients that are really targeted at what caused that cancer and how can we get at that unique aspect of this cancer. So this is something we really don't have in small cell lung cancer. And although I kind of talk about them as, these are really two very different cancers, although they're in the longest. Yeah.
So how do you differentiate between a small and a large cell?
And so that would be,
Judgment call?
It's not my judgment call. A pathologist essentially can look at them and judge based on how they look under a microscope.
So do you physically measure it?
They can. I don't know if they actually measure it, but they can just look, and based on their kind of background and knowledge, they can look at the cells look very different when they actually look under a microscope. So that somebody, a pathologist, or an expert in diagnosing cancers, can look at these and say this is, a non-small cell lung cancer, a small cell lung cancer. There are also some molecular tests that can be done, but really this can be done just by looking at it under a microscope.
So it's a judgment call by a very qualified person.
Yes, essentially. There's a variety of criteria that go into it, and I don't know all of them, to be completely honest, but there's different aspects that they look at.
There's got to be some that are borderline.
Absolutely, and there's some that, and this is something I'll briefly touch on, but there's some where it's actually, you might have a mixture and you might have both types in there, and those are maybe even more challenging, because how do you treat two different types of cancer that are in the same tumor? So yeah, just getting to that essentially is although these are two different types of cancer, we do have situations where we can have mixtures of the two, or we can actually have one turning into the other. So you can actually have a non-small cell lung cancer, in some cases, turn into small cell lung cancer as a mechanism of developing therapy resistance. So you treat that patient with non-small cell lung cancer, and it can actually turn into small cell lung cancer to become resistant to the therapy. And so really my areas of research are focused on, what's going on in small cell lung cancer to cause these cancers, so that we can try to get at that. And then another area that our research is really focused on is in these situations where these cancers actually change as a way of developing drug resistance. How do they do this? And can we find a way to actually block that? And so before I get too much into my research, I won't talk about it too much, but I want to talk about kind of where we're at with small cell lung cancer, kind of, from a research point of view, and how it's, changed and evolved, and maybe where we can go with this. So for a long time, and still really to this day, small cell lung cancer, for a long time it was viewed as one disease. So all small cell lung cancer is the same. And we know that's not true. That is how it's viewed for a long time, and it's still how it's treated. So there aren't really a lot of differences. And so, but what we're starting to finally learn is that there are different types of small cell lung cancer, and there's some kind of observations early on, although this didn't really impact, treatment. We didn't really know what it meant. But much more recently, we're really starting to learn that there are different types of small cell lung cancer. And this is based on not necessarily how they look, but when we look at kind of the underlying biology, the underlying kind of molecular features, these are the types of things that I look at, there are very drastic differences. This is still very recent, and ultimately we don't really know what it means yet. There's some hints in the research and the literature out there that maybe these different types are sensitive to different treatments or different drugs, but we really don't know yet. There's just some hints of this, and this is what we're truly trying to get at. And there's also some ideas in the literature that although these are different types, cancers actually have the ability to change and jump between those types, potentially as a way of developing a drug resistance. And then we run into these situations where now that we know that there's these different types, we have tumors that have those different types within them. So one tumor that has these different types all mixed together. And then we layer on top of that you can get, non-small cell lung cancer turning into small cell lung cancer. So, we started to learn a lot more about the underlying biology, but we still don't really know what a lot of it means. And so that's partly where my research is focused, is really trying to understand the underlying aspects of this. What does this really all mean? Because again, we don't really know. And ultimately, what does this mean for treating patients? And so I won't go into this list, but these are some of the areas of interest in my lab is, what's the relevance of these different types of small cell lung cancer? Does it actually mean something, or is this just more observational? Does this mean something for treatment? And how and why do these occur? How do they arise? And what's unique about each one? And so my lab has really, I guess, two major themes right now in our research. It's really to better understand kind of the underlying biology behind how small cell lung cancer arises. How does it progress and change in patients and change throughout treatment to eventually become, drug resistant? And then we also have a large focus on understanding how does non-small cell lung cancer turn into small cell lung cancer? How does it essentially a cancer completely change what it looks like? And they can do this to become drug resistant. So by understanding how they're able to do that, maybe we can find ways of blocking it. That's the ultimate goal. And so there's lots of different ways that this could be approached from a research point of view. How my lab approaches it is we study how cancer cells control expression of their genes. And ultimately, how is this different from a normal cell? And how does this change as cancer cells change and evolve over time? And so to kind of, I guess, understand the research, we have to understand kind of, again, the fundamental processes involved. And so our bodies are made up of trillions of cells, and within each one of those cells is all of our genetic material, our DNA. And within that DNA, essentially, is the blueprints to make all the genes that our cells might need to function. And there's about 20,000 different ones. But cells don't want to make all 20,000 genes at the same time. They might only want to make half of those. And a blood cell and a skin cell want to make completely different ones. And they might need to make different amounts. And so this is how they turn these potential genes into an actual product, is a process in the cells that's very highly regulated. And it's process called transcription, where you take one gene from all this genetic material, these blueprints, you turn it into a molecule called RNA. The RNA is turned into a protein, and the protein is actually what does something. So proteins can be things like enzymes, they can be structural things that actually form the structure of the cell. They can cause cells to grow, they can cause them to move around, they can do all kinds of things. Again, there's tens of thousands of these. But we're focused on this really early step, this very first step that says which genes are going to be made in this cell. This process called transcription. And this is controlled by these proteins called transcription factors. And what they do is they grab onto the DNA in specific spots right beside a gene, and they tell the cell if this gene is going to be turned on, and this gene is going to be turned on, and this gene is going to be turned on, and this one's going to be turned off, and this one's going to be turned off. And they really are what tell the cell what it's going to be. And so we study this process in the cells with the goal of trying to identify what's gone wrong in the cancer cells. And so I don't want to show a bunch of data, but I couldn't help myself, but I had to show one piece of data. So this is one of these proteins that we study, and it's called TEAD. And it's got a kind of a funny name. We find name, things kind of funny in science. And it's one of these transcription factors. So it grabs onto the DNA and it tells the cell which genes are going to be made or not made. And we had this idea that it might be important in small cell lung cancer. And so we did an experiment where we got rid of it in small cell lung cancer cells. So we grow these cells in a petri dish in our lab, and we can get rid of this protein. And we said, what happens to these cancer cells? And what we found is they started dying, which is exactly what we're trying to do. We want to try to find ways to kill these cancer cells. And so by getting rid of this gene, we're able to do this. And so our next goal is, now we can do this experimentally. Is there a way that we can actually do this with a drug, for example? And so these transcription factors never work by themselves. They always have to bring friends along to do this job. And all these friends jump together and they jump on the DNA and they do something together. And so we tried to find what are these friends, these partners of TEADs that are important. And we've identified some that we think are important, and some of these have drugs that work against them. And so now what we're doing is we're testing these drugs to see if they might be useful in targeting, small cell lung cancer cells, at least that we're growing in a petri dish in our lab. And then we also think that these same things might be really important in when non-small cell lung cancer converts into small cell lung cancer. So again, these same proteins that we're studying in small cell lung cancer, we think are important in this process as well. And so again, can we use these same drugs to target this, to prevent these changes, to maybe lock the cancer cells into a state where those initial drugs maybe are still going to be able to work. Yeah, and so that's kind of where the research in my lab is going. It's, I have a new lab we started about 1.5 years ago, so we're just kind of getting up and running with this research. But ultimately our goal is to really understand the underlying biology of these cancers, small cell lung cancer, so that we can identify, new, better ways of treating it that are really based on what's the underlying cause at kind of that molecular level. With that, thank all the people that help and that do the work and that fund the work. I'm happy to take questions if anybody has them.
I have 3.
Great. As long as there's time, I'm happy to answer as many as you
Are
want.
there drugs that differentiate between large and small?
Yeah, so there's, when patients are initially treated, the treatment for small cell lung cancer and non-small cell lung cancer are quite different. And small cell lung cancer will get a very similar treatment, all small cell lung cancers, but non-small cell lung cancer, there's a lot of different treatments depending on the type of non-small cell lung cancer it is and kind of the underlying causes.
My oncologist seemed a bit, I'm going to use the word relieved. He said, you got small. And he seemed a little happier than the large.
Okay.
Is that a fair assessment?
I would say if your oncologist said so, then yes. I don't want to step on their toes by any means. They might even be sitting in this room. I'm not sure. So I really don't want to step on their toes.
Dr. Joel said. The next question is, how do you share your information?
Like our research results. So we share them through events like this where we can present to different groups, sometimes the public or to scientific groups at conferences. We publish our work, in scientific journals, depending if people think it's interesting enough. We've had work that's been put on, different scientific blogs or, media and social media. So a variety of different ways. The traditional ways are we publish them in journals and we present them at scientific conferences, but the goal is to kind of move past that and get them, more kind of broadly disseminated.
Which leads me to my third question. Has there, or are you concerned that there could possibly be overlap in your research, let's say between us and Saskatchewan or something like that? Like you guys get together and say, okay, you take this, I'll take that.
Yeah, I don't want to say, there's always concern, but I don't want to say concern. I think it's really good that we're all working on things together. If somebody's working on something similar, you do want to know so that, there's no point in 2 people doing the exact same thing, right? So can we find a way to work together to be more efficient in our discussions?
You got a pretty good idea what the boys in Ottawa are.
The reality is there's people all over the world. There's so I cannot keep track on everybody, but I do know some people that work on similar things and try to keep in touch. And hope that we're, kind of synergizing and working together opposed to competing, right?
Well, the
or
reason I say
duplicating.
that, is I'm very happy, part of with CCMB. And I'm wondering, are you being asked by other institutions all the time? How you doing and what you doing?
I wouldn't say all the time. I mean, that would be very flattering if it was all the time. But yeah, I think, I think it's always nice when you get to present to people because then they see what you're doing, especially as a new person, right? I've just started my lab. So when you get to present to people and they get to see what you're doing, then that drums up maybe those interests and those opportunities to like work with other people and collaborate with other people. So I have people in Toronto that I know from when I was there that I still work with.
Is your lab here at HSE?
My lab is just 3 floors above us in the CancerCare building here. So in the new Paul Albertson Research Institute.
Thank you.
Thank you for coming.
Yes, thank you, Dr. Pearson. It's not often that we get to hear from small cell researchers, small cells always left out of this equation. So
Yeah, it's definitely, I think that.
yeah. Okay. Sorry, just fixing the camera there. So our next speaker is Dr. Craig Harlos. Dr. Harlos graduated from medical school at the University of Manitoba in 2010. He continued at the University of Manitoba and completed residency training in internal medicine, followed by his subspecialty training in medical oncology. He then pursued a clinical fellowship in neuro-oncology through the University of Toronto at Princess Margaret Centre, which was completed in 2016. He currently practices in the thoracic, head and neck and central nervous system disease group sites. Welcome, Dr. Collins.
So. Oh, like that. Okay. So it's great to have the opportunity to come and speak to everyone today. I'm going to be talking about personalized therapy in lung cancer treatment. And so hopefully with this talk, I'll be able to kind of go over where we've been, what kind of pathway we've gone to get where we are today in terms of personalized therapy, and some of the tests and tools that we use to facilitate that. So just to kind of reinforce the point of how important it is to be moving forwards with our lung cancer therapies and increasing the options that we have. So lung cancer remains one of the most common cancers that we see, representing 13% of all new cancer cases. And it unfortunately represents an even higher proportion of the cancer mortality that we see at 24%. And that remains the leading cause of cancer mortality in Canada. And just to give a quick overview for our talk, so what are the different tools that we have in our toolbox to treat lung cancer? And so there's a few kind of broad categories of treatments that our different therapies can fall into. The first being what we call cytotoxic chemotherapy. So this tends to be the more traditional version of chemotherapy that people think about when they hear that term. And these are medications that interfere with DNA synthesis or produce damage to DNA that ultimately lead to death of the cancer cells. Another category would be targeted therapy. And this is specifically a cancer treatment that targets certain proteins that control how cancer cells grow or divide and spread. These can fall into either what we call small molecule drugs or monoclonal antibodies. And finally, immunotherapy, and this is a broad group of treatments that essentially work through the immune system to help the body and the immune system actually go after the cancer cells themselves. And so this was discussed in our last talk about the different types of lung cancer that we see, both small cell and non-small cell. This talk is going to be focusing more so on the non-small cell lung cancer category. Again, a lot of the more personalized therapies, more targeted therapies have been identified and evolved in this space. And so within non-small cell lung cancer, we see the main breakdown of the main kind of tumor types, what we call adenocarcinoma, squamous cell carcinoma, and then various other types, including large cell carcinoma. And that's essentially a description of how these cells look under the microscope and how they stain, but there are important differences in terms of how they behave and what kind of alterations they may have as well. And so in terms of the traditional treatments, so the cytotoxic chemotherapy group of treatments has long been sort of the backbone of lung cancer treatments. Typically, this comes in the form of what we call platinum doublet chemotherapy. So one of the drugs that we use is kind of in the family of chemotherapies called platinum agents, and it's paired with another medication for best effect. Previously, all platinum doublets kind of seem to be equally effective, particularly when we look at the treatment of more advanced non-small cell lung cancer. But in 2008, there was a study that demonstrated that actually there is some importance when we look at the histology between adenocarcinoma and squamous cell carcinoma, that those two different types of non-small cell lung cancer actually responded a bit differently depending on the medications that we use. And so a combination called platinum pemetrexed actually worked better for adenocarcinoma, and platinum gemcitabine was better for squamous cell. And so that kind of began this path of actually having a more personalized approach to therapy for non-small cell lung cancer. Shortly after, there was identified a particular protein and a mutation in a gene and protein called epidermal growth factor receptor, or EGFR. And this particular protein exists kind of in the cell membrane, and I'm not sure if I have a cursor here to show somewhere. There it is. All right. And so we know that these proteins, and this is true of many of the kind of targets that we have, but EGFR being one of the more common ones we encounter in lung cancer. It exists kind of on the cell surface here, and there's a signal that comes and binds to that, and that kind of initiates a process that starts this whole signaling pathway that then leads to cell growth and proliferation. What was found, though, is that in certain cases, lost my cursor a bit, this can kind of get stuck in the on position. So this on the interior of the cell here is what we call a tyrosine kinase domain. And basically, if that gets stuck in the on position, basically this signaling pathway continues to produce that signal that the cell should grow and proliferate, leading essentially to the development and sustained growth of the cancer. And so it was found that about 15% of adenocarcinomas had that mutation. It tended to be more prevalent in patients, and this was kind of discussed earlier, the non-smoking population, but patients who are younger, non-smokers, women and of Asian descent, that could be up to 50% of those patients could have this particular mutation. And so there was then an explosion of trials looking at medications that could actually target this mutation. And so these medications, it's a bit small to read here, but drugs like gefitinib and erlotinib, these kind of fell into the category of small molecules, those targeted therapies that could block that signal, basically block that kind of overactivated pathway and result in shrinkage and control of the tumor. And this seemed to be surprisingly more effective than our standard chemotherapy options, basically changing our whole treatment approach to these cancers. And so this was a recent study. This was using a drug called osimertinib, and this was actually compared to not just chemotherapy, but some of the other targeted therapies, and found to be superior to those targeted therapies. So we're kind of developing more effective targeted therapies to go after these mutations. And with the identification of more of these, just want to check one thing. Not sure if I skipped a slide here. There might be a couple of slides missing, but that's okay. I can make that work. So yeah, there should be a slide in there kind of looking at additional targets that we can go after in lung cancer. So the EGFR mutation was one of the first ones that we identified, and it's one of the more common ones that we've identified, but there's been further research, further identification of specific mutations that function in a similar way, that kind of drive the growth of those tumors, kind of what we refer to as driver mutations, that we've subsequently developed medications that can target those mutations. And so there's kind of a long list, and they unfortunately don't occur in the same frequency, but things like there's ALK mutations, ROS1 mutations called NTRK. It's an ever expanding list, which is great. And there's been very active research in terms of drug development to go after those specific mutations. One of the limitations is that a lot of those mutations seem to occur predominantly or only in lung adenocarcinoma. And if we kind of look at the overall picture, it's perhaps only about 20, maybe up to 25% that have one of these mutations. And so with EGFR, in all comers, it's probably about 15%. For ALK, it's maybe 2 to 3%. And it gets to be kind of smaller portions of the overall population that have these mutations and therefore would benefit from those more targeted therapies. A lot of the work has been done for these targeted therapies in more advanced stages of cancer, what we refer to as stage 4. But because of their success in that space, it's moving on to other indications. So these are a couple of recent studies that looked at the use of these targeted therapies for patients that have undergone surgery and then trying to use additional treatments like traditionally chemotherapy, but now targeted therapies to decrease the risk of the cancer coming back. And so we're expanding kind of the role and the indications for these therapies. And so another form, another tool in our toolbox is immunotherapy. And there's a lot of different types of immunotherapy out there. The one that we most commonly use in lung cancer is something called checkpoint therapy or checkpoint inhibitors. And so how that works, let's see if I can put my pointer back here. So this would be the tumor cell and an immune cell that's going hunting for any abnormal cells. And the way that it does that is that it would identify an antigen that's not supposed to be there and essentially start an immune attack on the tumor cell. The immune system is a pretty complicated and well-balanced system. It needs to be activated, but it needs to be turned off or inhibited as well. Otherwise, we get overactivation of the immune system, autoimmune conditions, and things like that. And so some of the checkpoints that keep the immune system under control are things like this, this process here with PD-L1, the signal that can attach to PD-1 on the immune cell. Now, the tumor cells can take advantage of that process that's supposed to be here, but use that sort of signal of inhibition to hide from the immune system. And so these immunotherapies that take the form of monoclonal antibodies can go and block that signal, either by blocking PD-1 or PD-L1, and then allow the immune system to then attack the tumor cells. There's some other targets that we can use, including one called CTLA, but the PD-1 and PD-L1 inhibitors are the most common ones. And what we know, like the initial studies kind of went back to 2015 when immunotherapy really came on the scene for lung cancer, with some large trials that demonstrated its benefit for later lines of therapy. With further studies, we've recognized that the PD-L1 status on the tumor itself, so how much of that PD-L1 is expressed on the tumor, is important in terms of how likely a response is to occur with immunotherapy. And so this is kind of an outline of how that might be tested. There's a few different ways that we can test that, but we know that with high expression of PD-L1, patients can actually do very well with immunotherapy on its own. And with PD-L1 that's lower, the combination of immunotherapy with chemotherapy, so combining a few of those tools, is the most effective treatment. And so as with the targeted therapies, given the success of immunotherapy in the more advanced space, we're now seeing a lot of indications for immunotherapy in lung cancer, in both treatment of stage 3 disease after chemotherapy and radiation, after resection, and before surgery as well. And those PD-L1 markers and that testing can help inform us who the best appropriate patients are for these treatments and what we anticipate the benefit may be. And so how do we answer some of these questions? What are some of the investigations that we use to determine who has these mutations? What kind of cancer are we dealing with? That came up in the previous talk as well. And so there's a few different ways and a few different types of tests that we use to answer these questions. So histology, which is the more not basic, but sort of traditional approach that the pathologists use, is when we're actually looking at the cancer cells under the microscope, determining what they look like, what their architecture is. Certain stains can give us more information. And that's kind of how we determine, is this a small cell, a non-small cell, an adenocarcinoma, or squamous? Testing called immunohistochemistry that can use antibodies to check for certain antigens or markers can give us additional information that can kind of help us confirm that it's something like an adenocarcinoma. Can also tell us, is this an adenocarcinoma that can come from the lung or from the colon, because they can look different. And it can also help us detect expression of certain genes, for example, the ALK mutations. And then getting into some of the more the newer and perhaps more complicated testing is the molecular and genetic testing that can be performed. And so this is actually looking at the what's going on at the genetic level to detect the presence of certain alterations and mutations that can then inform both diagnosis and treatment. And so this is just a few examples of some of the different tests that can be used. So there's tests that can look specifically for a single gene. Again, we can use immunohistochemistry or something else called FISH analysis. There can be these multi-gene hotspot panels. Now this can look, can be sort of a single test that can look at multiple different genes at the same time. There can be more comprehensive genomic profiling. So this is a more complicated in-depth test that can provide up to hundreds of genes based on sort of a single run of this test. whole genome or exome sequencing that basically looks at a fully comprehensive test of the entire genome, which would be a lot of information, and RNA sequencing as well that can look at select transcripts of interest of gene expression or fusion gene detection. So this is an example of a multi-gene hotspot panel, and actually the one that we use here at CancerCare. And so this is kind of a list of all the different genes, nothing to memorize, don't worry, but all the different genes that we can test with one of these panels, and you'll see many of them up there that are the genes that we're interested in lung cancer and potentially offer targeted therapies for. And so one of the challenges with this whole process is that it does take time. And so getting a biopsy back, getting the histology report back, doing these additional tests, we can be looking at several weeks in terms of turnaround time. There are some newer testing, and this is something called a cartridge-based PCR. That can look if we have sort of questions about a specific test, like if we wonder if this patient might have an EGFR mutation and want to get that answer fairly quickly. These tests can be done potentially in hours as opposed to days or weeks. We do get those fast results as an advantage. Disadvantage, though, is that they are sort of more limited focused tests. We don't get that same kind of comprehensive panel that we might with the hotspot type testing. This is another kind of, I guess, step up from the hotspot panel, more comprehensive genome profiling that can detect essentially multiple gene alterations simultaneously and multiple different types. So this is something that I didn't go into in too much detail, but there is many different types of these mutations and alterations that we can see, like base substitutions, deletions, changes in copy number as an example. And these are the tests that can potentially give us information on hundreds of different genes that could be applicable. Because of that increased information, there is an increased cost and it does take more time. So again, advantages and disadvantages to these various approaches. And as we kind of further integrate some of these approaches, this could potentially change kind of how we approach our diagnosis and the steps toward treatment. So instead of just getting a biopsy and waiting for the pathology and adding the additional tests, we could potentially get the biopsy, run a more rapid focused test. If that's negative, do a more comprehensive approach, which might lead to targeted therapy options. And if that's negative, look at an approach more with the chemotherapy, immunotherapy treatments. And this is another very interesting method of detecting these mutations that actually does not require a tissue biopsy, but uses a blood sample to detect what we call circulating tumor DNA. Another word for it is a liquid biopsy. And so with a tissue biopsy, there's pros and cons to that approach. Of course, getting the tissue helps us look at the cell architecture and make that diagnosis in terms of an adenocarcinoma. With that tissue, we can then run the additional samples and test for various mutations. However, tissue biopsy is an invasive procedure. It does require putting a needle in and accessing the tumor. Sometimes the tumor itself is very hard to access and might not be in a place where it's easy to get a needle into. And so the liquid biopsy can help with that. It's not just kind of a standard blood sample, but one that can be drawn and sent off for similar molecular testing to get our information that way. So definitely a lot of new options and very interesting approaches. And in terms of how has this impacted sort of these additional options, the additional testing, how has that impacted our treatment pathways and what we can offer? So if we were talking 15, maybe 20 years ago, this would kind of look like, as an example for treatment of a more advanced or stage 4 non-small cell lung cancer, this would kind of be the algorithm that we would be able to offer. It would be our platinum doublet chemotherapy. Taxane is another type of chemotherapy that we know has activity kind of after progression if the platinum doublet does not work. Whereas now it's a lot more complicated, which is certainly a good thing. We now can give different treatments depending on whether it's a squamous or a non-squamous. This kind of end of the table goes off quite a bit off the slide because of all the different mutations that we're able to now target. And of course, the use of immunotherapy in those situations where we don't have those mutations to target. And so hopefully this will continue to look larger and go further as time goes on. And with sort of the increasing use of molecular diagnostics, that also has the potential to change kind of how we approach our diagnosis and our approach to treatment. So with our current approach, we have the suspicion of cancer, investigations, we get our histologic diagnosis, and then follow up with our molecular diagnosis. We have the potential with increasing advances in our knowledge of the molecular biology and genetics of cancer to potentially move directly towards a molecular diagnosis. So it's a question in the future, potentially, of how much a histologic diagnosis will really be required, or how much that will contribute to our approaches to treatment. So that's what I had. I'd be happy to take questions. Yeah.
Is tissue biopsy more towards the front end of things in diagnostic, or do the doctor said, we got to get a tissue sample? Right? At what point, because you said it's invasive and painful, does it generally come at the beginning of the diagnostic, or?
Yeah, so basically, with our ability to kind of give a diagnosis and give treatment options, we do still need that tissue sample. That is a very important part of our ability to say, okay, what kind of cancer is this? Our ability to do a lot of these tests. And so, you know, the liquid biopsies and ctDNA, it's a very interesting advancement and potentially an option. It's not something, though, right now that can necessarily replace a tissue biopsy.
So if nothing shows up on the liquid side, they pretty much say we got to go in for a tissue.
Yeah, so right now the liquid biopsies, they don't sort of exist at the front of our diagnostics. There's challenges with them. They're not sort of standard for all tumors. The presence of the tumor DNA in the circulation, it may not always be there to allow for that detection. And so we still want, in an ideal situation, a biopsy from basically all of the tumors. But it can function as a good companion piece of information, or sometimes on follow-up to detect kind of changes that might occur, especially in cases where we can't do a repeat biopsy. It has a very good role.
I'm thinking with a lung biopsy, ouch.
Yeah, and they can be painful. Of course, they try and do them as painless as possible with local freezing, and there's these people are highly trained on getting the biopsies done. So it's not guaranteed to be a painful procedure, but there remains that possibility. So in certain situations, if that can be avoided, that's nice, but the actually getting a tissue biopsy still remains very important for our.
So if you're already on a regime of chemicals, and you know, and this and that, there's probably a strong chance they won't go in for a tissue analysis.
Well, it depends on the situation. Sometimes we don't need, like if there's a change, we don't always need to do another biopsy, but in some cases it can be very helpful to get additional tissue. And in that situation, some of the liquid biopsies can be helpful.
I'm thinking that tissue tells you a lot of stuff.
That's where you get all of that information from. Yeah.
It's a good thing for you guys, but it's hard on us.
Well, that's true. Yeah.
Yeah, okay. Thank you.
How many biomarkers
Yeah.
can you test here now? In Manitoba?
So for in the for the hotspot testing or yeah, so right now I think it's about 34 or 35 genes that are on that panel. If there are genes that are not on that panel, we can also request them specifically, because not all of them that we necessarily want to know about are on that panel. But there is work being done that hopefully should be available to us in the near future to have a significantly expanded panel that's done locally. Yeah.
With the biomarker testing, what stage of lung cancer do you do that? Is it 4 or 3? Like when do you do those panels?
Yeah, so it's a very good question. And historically, it has been pretty much exclusively for stage 4. That's where most of the data has been for the benefits. But there is now a few trials that have demonstrated, especially for EGFR and a very new one with the ALK mutation, that's doing that earlier for stage 2 or 3 disease that's been resected. That opens up some additionally beneficial treatment pathways if we use those drugs. And so we are moving towards doing testing earlier because some data now shows that those drugs are useful in that space too.
But is it just for a couple like EGFR and ALK and those kind of thing, or are you doing the 40 or 35 or whatever it might be?
Yeah, well, a lot of the way that we get that information, like looking at the EGFR, is with that panel. Right now, though, we just have the data for those particular agents kind of in the earlier stages of cancer. But again, there's always new research going on. So, yeah.
So I'm pretending you guys are in a lab or whatever. You say to your fellow doctors, we got something here. From that point on to when the Pfizers of the world take it over and maybe make something out of it, are we looking at 2 years, 5 years, a year? How long does it normally take for a new drug to come to market?
Yeah, it's a good question. I might not be able to give the clearest answer to that, but it is a process. And so, you know, we have these different phases of evidence and testing that things go to. So as was discussed, kind of the work in the lab, trying to find these new targets and new medications. If there's something promising that goes to what we call phase 1 testing, where we kind of get a sense of the safety of that drug in people and maybe a bit about the efficacy, then needs to go on to phase 2 and eventually the phase 3 testing, which is those kind of big trials that are comparing newer drugs to our standard of care. And so that's a process that can take many years to develop. Yeah. Sometimes, you know, when things are looking promising, the drug companies allow us some early access to like a compassionate access program. We might be able to access it before it's kind of been fully funded, and because that's the other thing as well, is that it needs to go through government and be funded as well. So it can be a very long process, and unfortunately, many of the drugs that we try don't make it completely down that pathway, because many drugs in the earlier phases don't show the promise that we had hoped, and so it's a long and complicated process, but
Okay,
it is making progress. Yeah.
last question for you.
Yeah.
Chemical toxicity. is that more prevalent nowadays, or was it before, let's say 10 years ago, or how do you guys really deal with that properly?
Do you mean like toxicity from the treatments?
Yeah.
Yeah, and so it's another good question. And so a lot of the chemotherapy drugs, when you kind of think of the traditional chemotherapy drugs, there's nausea and vomiting and infection. With I'm guessing that might be the last question.
Yes.
But getting it. But some of the therapies, like, they still have toxicity, but a lot of them do seem to be gentler than the standard chemotherapy. So like the immunotherapy on its own or some of the targeted therapies, they do tend to be a bit easier to manage. Not free of side effects, but better.
Just one more question, because
Okay.
it's mine.
Okay.
Are there any
Thank you.
Canadian companies doing liquid biopsy now that Connexia is shut down, or?
Yeah, that's a good question. So there was that opportunity for us to use Connexia. In terms of a Canadian option, I'm not entirely sure.
Is it just
I've
Foundation
got
One
the
now?
so there's the Foundation One option. I've got my colleagues in the back there that I see are shaking their heads. So I think the
Oh,
answer is
okay,
no. in
the answer
terms
is
of,
no. Okay, I thought so, but I just wanted to know. Thank you so much. So we are quite a bit over time, but I mean, we have saved the best of our presentations for last. I'd like to introduce Alyson Haiart. Alyson has spent the last 11 years of work as a social worker at HSC. Prior to that, before leaving the United Kingdom, she worked as a registered nurse. Since taking early retirement, she's enjoying time with family and friends, exercise, painting, and traveling. Since the diagnosis of stage 4 non-small cell lung cancer, she has been raising awareness of lung cancer from being interviewed for an in-depth article. Whoops. By the Winnipeg Free Press journalist in November 2019, a radio interview by the CBC local weekend radio host, and also during Lung Cancer Awareness Month. She's also part of a CCMB multimedia awareness campaign. Welcome, Al.
Okay, thank you. Can you hear me speak? Yeah, okay, good. A few of us have come with these ribbons. It's the Lung Cancer Awareness White Ribbon Project. And there's a wonderful lady down at the front, don't stand up, Kelly, named Kelly, who, if you're interested, if you're interested in having one of these ribbons, speak to her at the end and she'll take care of you. I think her and her husband make them in the back.
My kids.
Yeah. Yeah. It's an awareness campaign that actually started in the States and is worldwide now. So I'm going to tell you my story from diagnosis of lung cancer to living a good life with stage 4 lung cancer. And the goal of this story is to offer you some hope. As mentioned, I was working as a full-time as a social worker when I was first diagnosed. I'm one of those non-smokers, no symptom patients that it was just picked up as an incidental finding at an annual physical that I had. That led to more chest x-rays, that led to a chest CT. And then when I had to go back to see the doctor to get those results, I was a little bit surprised because his receptionist phoned me on a particular Wednesday to say, oh, your doctor wants to see you today. And I said, but I'm seeing him on Friday. No, he wants to see you today. Well, I just presumed that was because he wanted to go golfing on the Friday, but it wasn't. So August of 24, I was diagnosed as having suspected stage 3 lung cancer. Yeah, my partner Dominic had picked me up and took me to the appointment, and we were just sidelined by the results. As I mentioned, never smoked, no symptoms, running on a regular basis, working full time, busy doing lots of things. Anyway, my family doctor sent an urgent referral to a thoracic surgery, and that's when I had my biopsy in a major lymph node just to the left of my sternum, chest bone. And as you were saying about, it can be painful, but this back in 2014, this was done under general anesthetic in day surgery. So I didn't really experience any pain from that. And I'm supposed, like all of you, when you get a diagnosis, like any type of cancer, you think you're not going to live that long. Anyway, Dominic drove me back to work because my car was still there. And he came with me whilst I showed my boss a copy of my CT report. She was very, very shocked, but she understood and said, take some time off. And my next stop was to go up to the department I was working. And I'm a sharer. And I knew that if I shared it with my team, I would get a lot of support. So they also had to cancel any appointments that I had for the next few days. I also had to tell my two adult kids, two adult kids in university and one living in Australia. My mum, who was in a nursing home at the time, and my sister and her husband, and Dominic told his family as well. And again, as I said, I'm a sharer, so it was important for me to tell my neighbours. I've known them since 1993, and this was 2014. So my kids had grown up with their kids, and we all knew each other extremely well, so that I knew they would offer support both to Dominic and to my kids when they were at home. Yeah, so when I got the results from my tissue biopsy, my surgeon at that time said to me, "Don't be Googling the life expectancy results." Well, of course, what are you going to do? And I'm sure you did it as well. You Google the life expectancy results. And, as he said, the stats are out of date. So, take them with a bit of salt, but you still Google it. I then went through a myriad amount of testing. And the only molecular analysis at the time was the fish testing that was mentioned. And that had to be, my specimen from that biopsy had to be sent off to, I can't remember, is it San Diego?
Seattle.
Yeah. Oh, Seattle. Yeah, thank you, Dr. Straw. So when that came back, I was told I was ALK, and that was great news, because if I ever progressed to stage 4, there would be oral chemo available to me. So yay. I ended up having 25 rounds of chest radiation with 2 rounds of chemo on the first 6 days and the last 6 days. I took my medication as prescribed, and then only on one occasion did I have to take some breakthrough breathing for nausea. Yes, I lost my hair, had a metallic taste in my mouth, but was determined to go on with life. And a really great benefit? I got chemo waves. My hair was the straight as pump water before. I was offered a wig from the guardian angel room, but I only wore it a few times when I was going to visit my mum, who was living in a nursing home. And finally, she said it was okay for me to turn up with my bald head. And then there was the wait for the CT scan. CT, I think about a 6-week stage. And that's when anxiety starts. And it continues to this day. Usually just the night before I get the results, I don't sleep very well of any CTs or MRIs. So living with lung cancer is really a roller coaster of hope, anxiety, and relief until the next set of treatments. Well, it wasn't great news. The scans showed that the chemoradiation had minimal effect on my tumors. The tumors were in my left upper lobe. So after a myriad of testing, making sure I had good lung function testing, in case I had to have a total removal of the lung, I was referred to a thoracic surgeon who offered me an upper lobectomy of my left lung, but I had to be aware that it might, because I'd had previous radiation, I might have to have a total lung removal. Well, it was about that time that I decided, okay, I've got these things. I'll start thinking positive thoughts about my lung cancer. I think I had spiculated cells and some others. And so I used to, because they were on the apex, my left upper lobe, I used to think of them as Christmas tree lights. And, you know, I used to try and think positive thoughts about them, because I'm weird like that. So this was a different, my original thoracic surgeon had retired, so I was introduced to a new one. And I had my surgery in March 2015. And thankfully, I only had the left upper lobe resection, thanks to the skills of this surgeon, who has since left HSC and has gone to Kelowna or somewhere like that. So I had my left upper lobe removed, a whole lot of lymph nodes in my chest. And prior to discharge, I had to have 2 units of blood just to keep my oxygen levels high enough. I was continued with the breathing exercises I had to do, walking inside and outside bit by bit as the weather improved, because this was March. The hardest part of being home, I found that when I was in hospital, the nurses were coming in or you were attached to machines and someone was checking on you. At home, no one knows. No one would know if I died during the night. So that was a worry for me, but obviously I didn't. And then thanks to the pre and post surgery, I participated in most of the lung CancerCare Manitoba patient programs, which I found really helpful. And then thanks to having the left upper lobectomy, I had no evidence of disease. But however, even though I loved my job as a social worker at HSC, I decided I would take early retirement once my disability had ended. So I just felt I wouldn't be able to work and continue with everything and fulfill my bucket list. So I started running again. I went to a meditation group, volunteered at a couple of organizations, and more importantly, for me, started painting. Having lessons initially at a well-known local art supply store. And I think of painting as the gift that lung cancer gave me. And then travel to Europe and Australia, resume. And the reason I go to Australia is my son is still there. And at the time I was diagnosed, he was a junior doctor in Adelaide. So I knew my other 2 sons would have lots of questions for him. So unfortunately for him, he got that role. On another note, I want to mention radon, as was mentioned by a question down here. Radon is an odorless radioactive gas released from the breakdown of uranium in the soil and bedrock. We tested for radon following my lung cancer diagnosis or cancer treatment. Health Canada says that 200 becquerels is a safe amount, whereas the World Health Organization said at that time 100 becquerels is a safe amount. So anyway, we used 2 radon detecting pucks for 3 months during the winter when the windows were closed. 1 on the main floor and 1 in the basement, which was finished. The main floor reading was 400 becquerels. The basement reading was 700 becquerels. So there was no question about it. We had to have it mitigated. So I obtained a list from CancerCare Manitoba and, you know, of people that we could phone. And then when we retested, I can't remember, a year or so later, we were down to 70 becquerel, about less than 70 at each level. So as a way to giving back to CancerCare Manitoba, I'm a patient advisor, and this gives me many opportunities to take part in projects. Like I took part in the Nuna app, whether you love it or hate it, and different other things. And I'm also a peer-to-peer volunteer support person with Lung Cancer Canada. There's a fantastic lung cancer support group run by a social worker here at CancerCare Manitoba. We used to meet in person, and then due to COVID, we could only meet by Zoom, and we still meet by Zoom. And this, I think, is best because it gives access to people who live outside of Winnipeg. If you're not feeling well enough to actually physically come to a group, it's on Zoom. So I think that's the best way to do it. And again, wonderful lady here gets us all together twice a year for social events. So we all enjoy that.
Not standing up this time.
No, you have to be part of the support group to get the invites to those. So join. I've also been doing, I did several exercises, an exercise program, people who have had cancer or are currently under treatment with any type of cancer. And I was doing it via Zoom, and it's called XL, which is Exercise for Cancer to Enhance Living Well. And this program is offered through the University of Calgary Kinesiology Department, and CancerCare Manitoba has information about that group. Anyway, fast forward to December 2017. After almost 3 years of having no evidence of disease, I started having vision difficulties. So eventually that led to me having an MRI of my brain, my first of many MRIs. And then a cancer care oncologist doctor who was on call phoned me back that same day, the 27th of December. It's funny how certain dates fit in your mind, stick in your mind. Anyway, they said, you know, they were asked lots of questions, then eventually said I had, you know, brain mets. And so that because one had a large cystic component, she sent a prescription for dexamethasone to my local pharmacy so I could start that. And then by the second week in January, I got to see my new radiation oncologist. My case had been discussed by the gamma knife surgeons, the neurosurgeons, and the whole brain radiation oncologist. And the only option that was offered to me was the whole brain radiation. So it's not what I would have chosen, in part because of the potential for long-term side effects, especially cognitive issues. But I thought, hey, I'd rather be alive and run the risk of getting of those than the alternative. So, touch wood, because that was in January 28, I had 12 treatments of whole brain radiation. I think I'm doing quite well, really. Whole brain radiation is very tiring. It's fatigue. It accumulates over time. So your treatments may have finished, but the fatigue continues to build. So again, that took Again, it was winter, so it was, walking inside, walking in malls, walking around IKEA, trying to increase my tolerance for exercise again. And still my hair grew back curly. Oh, wavy. So what was that? It's almost finished, I think. Yeah. And I realized that my journey is different to other people's with lung cancer. I knew that and I do count my blessings. I do realize I have had a relatively easy time of it. I do count my blessings, and I know that my cancer will at some point progress as it becomes resistant to alectinib, which is the oral chemo I was put on eventually after my whole brain radiation. I think continued drug research and approval from the Canadian Drug Agency, which always looks at a cost-benefit analysis of which drugs they will approve in Canada. There will be more options for treatment at that time, and maybe that the new National Pharmacare program or insurance companies will cover that. So here I am living a good life with stage 4 lung cancer, continuing to travel and off to Europe and Australia this year if my scans remain stable. I am thankful to my oncologists and their staff at CancerCare for their knowledge, wisdom, and compassion. Thank you for listening. Want to take questions? Yes.
When you got your surgery, was that because you were at stage 3 or were you already at 4?
No, I was at stage 3 at that time.
So if you were at 4, they probably wouldn't have done that then.
I'm presuming they wouldn't. I'm not quite there.
Okay.
Yeah.
Well, good for you.
Thank you.
You look great, buddy.
Yeah, thank you very much. Yeah, I feel good.
Yeah.
Yeah. Don't forget.
Oh, thank you so much, Alyson, for sharing your story with us. Our next speaker is Corie Haselback. Corie worked as an occupational therapist at Misericordia Health Center for 29 years until her stage 4 lung cancer diagnosis at the age of 53. She and her husband Mike have 3 young adult children and are grandparents to one-year-old twin girls. She has educated, since her diagnosis, she has educated people about radon gas and supported others who have been newly diagnosed with lung cancer. She advocates for the Canadian EGFR exon 20 group. She plays badminton and pickleball and helps and spends time with her mom, who also has lung cancer. Welcome, Corie.
Thank you. Thank you for inviting me and for hosting this. And I'm going to say right away, thanks to CancerCare Manitoba for all the support and care that has been given to me. So I'm going to start back in 2016 when my lovely dog, Sammy, was diagnosed with lung cancer and died. And, didn't think much of it, except sad, of course. But I do go, was that a clue? Anyway, regarding the radon, because he lived in the house all the time. Anyway, fast forward to January 2020. My husband and I were on vacation, early 2020. We were hearing about COVID, but there was some stressful stuff going on in my life. And I had this just discomfort constantly in my chest, but it would kind of go away. And then, if I could stay calm, not too bad, but it was enough that I spoke to my doctor about it when I got back, and she ordered an EKG, and we kind of dismissed it as heartburn. So that was this weird symptom that, wasn't really present, but was there. And I think intuition tells us things. fast forward to, and of course, then, you know, we all had COVID and life was stressful for everyone. So then what happened to me, and I've lost my page, but that's okay, I can tell. And I will say, so this pain in my chest, I still get that, but that's the only time is if I'm stressed. If I can stay calm, breathe, I really don't have symptoms. I don't really feel that bad. May 2021, I went for my breast screening mammogram and just had to walk down the hall from my work where I worked at Misericordia for it. And I'm like, okay, getting this done, check that off. And within a week or two, I found out that I needed to go for a second screening and then eventually to Breast Health Center, where it was identified that I had an early stage, very small early stage breast cancer. So I'm like, okay, I got this. Lots of women get breast cancer. Going to get this done and over with. So had my lumpectomy in July of 2021 and decided I'm going to take the time off work. It's kind of nice to be off work, spend time with my family. So thankfully I did. And then, you know, the tests for just to make sure that the cancer wasn't too serious or whatever were done. I didn't need chemo. And then October 6th of 2021, I met my radiation oncologist just for the preventative so that we don't get breast cancer come back, right? It's just like radiation 5 times. I'm going to get it done and over with. I was going to be done November 2nd. So anyway, went to the scan on October 8th. And I was like happy and like, okay, I get to start now. I'm going back to work next week. And got a call while I was in IKEA that Dr. Acker wanted to speak to me on Tuesday. And first I said, okay, I'll be at work. He can call me then. And then I hung up the phone and I realized I wasn't supposed to get that phone call. So I canceled my plan to go back to work because I just had a gut feeling. I had an intuition. They saw something on my scan. I knew it. Didn't know for sure what it was, but I had a gut feeling it was lung cancer. I just had a feeling. Anyway, so then Thanksgiving that weekend was pretty stressful, holding it back from my family. My husband and I knew, didn't really want to tell everybody, but we were worried. So then on the Tuesday, he called us and sure enough, they'd seen a tumor on my lung. So then lots of scans, right? And you have to go through, I went for a PET scan. I went for other scans. They found I had 3 tumors in my vertebrae, 3 different vertebrae. So I had stage 4 right away. So then waiting for, I had an EBUS, which is the procedure where they take the biopsy of my lung tumor. And it was something uncomfortable. I don't do great with anesthetic, but I survived. Wasn't that bad. I will say my mom was fortunate when she had her lung cancer. They could actually access it through the rib and just pull the cells out. So she didn't have to go down through the throat, but it wasn't that bad either way. So, anyway, so then my journey was waiting, but I also knew I was going to meet some pretty amazing people, you guys, and just made up my mind that that would be a big part of my journey, that I would reach out to meet people and that. So, found out that I was treatable, not curable, no surgery ever. Was waiting to find out my particular biomarker, I think about 7 weeks, which was very stressful. You don't sleep a lot while you're waiting and I will say like the tingles in my whole body and just like the stress of a new diagnosis like this, like set off so many things in me. It made me the sickest I was really like ever, just the stress of it. So then I found out that I have EGFR exon 20 insertion biomarker, which is one of the more rare EGFRs and is also one of the less, it's more resistant and it doesn't respond to osimertinib. So that is not a targeted treatment for me, at least at this point at the that level. But so the plan at that time was for me to do the chemo blood doublet of pemetrexed and carboplatin and also immunotherapy. And however, there was hope. I found out about the Exon 20 Facebook group, the global group. That's incredible, very amazing. And so had, interviews on the phone with people from Phoenix and a nurse that I can access anytime. And it's just, we actually have a weekly support group that we can access on Zoom. I can talk to them every single week and they become your friends, right? But anyway, so we went on to start that treatment. I had some, at that time in 2021, the FDA in the States had approved 2 targeted treatments for exon 20, one called mobocertinib and one called amivantamab. And so not yet in Canada at that time, for sure not. But it gives you that hope. You go, okay, if what I'm on now isn't going to work, then at least maybe I'll be able to get that. And there's been a lot of research and lots of things going around worldwide, like not as much as I'd like, right, Michelle, but it is, there's drugs coming, right? And there's also, it's important that these drugs can cross the blood-brain barrier, which currently the ones that I have available really don't. Because that's one of the problems, right? That we get problems with mets to the brain. So anyway, I started in December 2021 on my first round of 4, had great results for, some shrinkage of all my tumors, that both my ones in my spine as well as in my chest or in my lung, and then kept on just the maintenance chemo that's called pemetrexed, and I'm still on it. And tomorrow is my birthday, and I'm incredibly grateful to go for my pemetrexed tomorrow. Yeah. Yeah, it's been a very tolerable drug for me. I can basically bounce back in 2-3 days and go play badminton on Monday after I have it on Friday. So that's good. So then, I did stay on pembrolizumab, which is the immunotherapy, for a total of 6, but there was research in it that it really wasn't great for my particular biomarker. And also I had some unfortunate reactions, just I felt, and I ended up with thyroid issues. So anyway, I quit that one. Potentially, maybe there'll be another immunotherapy down the road that I can go on. I don't know. But for exon 20, it's not with a low PDL1, research isn't really supporting that. So anyway, carry on, do some travels. I had some struggles with, just coming to terms with it, and the anxiety and stuff was like, you're going to do a lot of thinking. You think a lot when you get this stuff come up in your life. And I quit work at that point. I really was sad because I loved my job as an occupational therapist and, wanted to be back at work. It certainly wasn't how I planned to retire, but I was approved for disability, and I'm super grateful for that. And I officially retired last year, and I'm still, on disability and stuff. But in the meantime, my poor mom had a lung collapse, and then we found out she had lung cancer. And then shortly after that, my mother-in-law was super sick, and then we found out she had lung cancer, and she died on December 31st, 2021 or 2022. So that was hard. Yeah, lots of lung cancer. Anyway, so then but I stayed on, and I just realized, once I got past the carboplatin, which was harder for sure, the doublet, and I didn't feel like it definitely took more out of me. Never got sick though. I didn't really get sick, but no loss of hair or anything. I kind of decided, hey, my life's kind of boring. I need to find some things to do. And that's when I found my badminton group, which I love, and play twice a week and stuff. And, done a little bit of travel, met great people through the lung cancer support group in Manitoba here, as well as through the Canadian Exon 20 group and our worldwide group. Anyway, so then, I had some radiation. Well, a year ago, my grandbabies were born at the same day as my birthday. So tomorrow's their first birthday. And we went up, I had radiation, I had to have radiation in my sternum and my ribs, because I've had some, what they call oligometastatic progression, which is like small amounts of progression in different spots that they try to treat generally with radiation if possible. So I've had that, I had that back in May of last year. And then we went up to the Yukon where my grandbabies and my son and family live and saw them. And I felt a bit tired, but I really didn't do bad. I felt pretty good. And then, you know, keep on. Then this past, so that was last year. Then in December, or like later in the fall, there was some, one of the nodules had gotten bigger. So then I had radiation in my lung, and that was the first and only time I've had radiation in my lung. But again, I did pretty good on it. Didn't really feel that tired or anything. And then but my radiation oncologist did want me to do prednisone, but I didn't do well on that. I was like, so that I stopped actually. He said, you have no symptoms, like you're asymptomatic. Let's see how you do without it. Because the scans, they were showing some, you know, stuff in the lung, and they weren't sure whether it was related to the radiation or whether it was related to other pneumonitis or progression. So anyway, I'm now back on that because we're still not sure. And then not too long ago, what date was it? March 23rd, I had my MRI. Oh, here's the thing. Follow your intuition, and just if your gut's telling you something's wrong, follow it. I kept feeling these weird little pains in my head. And anyway, so the MRI in my brain did find 8 small lesions. And at first the both my oncologists were super supportive and said, we want you to have Gamma Knife, and that's what we're hoping for. And then, but the neurosurgeons were in favor of me having whole brain radiation, which I bawled my eyes out when they told me that. I was at Badminton. I'm like, no, I don't want that, please. And so anyway, the neurosurgeon did agree to do Gamma Knife, and I had it a week ago yesterday. So I've had a bit of headache the first night, but I'm good. I really feel good. So yeah, you know, I've just been through this very roller coaster journey of figuring out, you know, sometimes it's just taking the step day by day. But I've also decided I'm not going to be a woe is me. I'm going to be a positive influence on as many people as I can be. I'm going to help as many people as I can, help teach them about radon, get it out of your house if you can. Like ours was at 500, I believe. And, you know, I think that's terrible. So we got it mitigated, and there is actually a program through Lung Association, Manitoba. I think it's where you can get some help with the cost of it. So that's great. We were able to get that. And then, yeah, help my mom. She has a different biomarker. She's got CRAS G12. She's been on immunotherapy, but that stopped. She's doing well. She's not doing great. She's got COPD. She's, you know, struggling, but she's pretty amazing. I guess I get a lot of the keep going and be positive from her. So, you know, but this brain met thing, I'll tell you, that definitely was a scary moment in my life to think, wow, okay, I got brain mets. And as an occupational therapist, I mean, I know an awful lot of what happens if, like, I was really scared of the whole brain. And I mean, I know you've done great on it, and I'm so happy for you, Alyson, but it was definitely, and I hope I don't have to go that route. Like, they're scared of microscopic ones that aren't being seen in the MRIs. So now my life is I go for CT scans every 3 months and MRIs every 3 months for the rest of my life, and keep on my treatment. My hope is, you know, a clinical trial, not necessarily, won't likely be here because it's quite rare mine, and I'd probably have to go to either Toronto or Edmonton, maybe. I'm sure hoping, and that's why oncologist is looking into. And we'll, yeah, hopefully pemetrexed sticks, keeps going, because I like it. But yeah, I could find out in June that might have progression, and then I have to change to a different drug, and that drug it's actually called amivantamab, and currently in Canada, it's only available if you were able to get into the compassionate access program, which ended on October 31st. So thankfully, my oncologist was on the ball and got me in on October 27th. So when I do have to switch to amivantamab, I have that available to me. So this is one of those ones that was approved back in 2021 in the States and the FDA. The other one, mobocertinib, that was an oral drug that you wanted me to go on next because you said this will be good quality of life, such an important balance, got pulled from the market, from the whole world back in October because of a sort of a failed study, really, which is kind of unfortunate. So, but thankfully in the exon 20 world, there are some newer drugs and there are some like studies coming up and we're hopeful. So, you know, I hope that I can give people hope and just, you know, I think you also have to, this brain med thing hit me that you gotta face reality too. Like, this is not good. Even though, you know, I'm trudging along, everybody says how fantastic you look all the time. And oh, wow, Corie, you'd never know that you have this. And I agree, and I don't even feel sick 99% of the time, right? So, but I think you start to think about things even further, like kind of back where I was, but I'm handling it better than I was. And I think acceptance and peace has come into my life more recently that maybe wasn't quite there. But anyway, that's my story. And it's great to be here. You know, I honestly, when I found out I had this, I really didn't think I'd make it to 56. Yeah. So here I am. Happy birthday. Thank you.
Birthday, Corie, and thank you so much. I know that you had second thoughts about coming today because speaking today, and I'm so happy that you did, and I think everybody else.
And it wasn't that I had second thoughts, but when I found out I had the brain mets and I wasn't sure how I'd feel after that, right? After Gamma Knife a week ago. I will add one little thing that I really like a book. It's called Radical Remission: Surviving Cancer at All Odds by Kelly Turner. And she is just like, it's a great book. And I would highly recommend anybody reading it. It just gives you hope. It gives you some strategies like the positive thinking, the trusting your intuition, advocating for yourself. There's like 9 things that she mentioned. So read that book if it's worth it. So yeah, but thank you, Michelle. Thank you so much. Yeah.
And last but not least, I'd like to introduce Carole Vivier. Carole was the CEO and film commissioner for Manitoba Film and Music for 30 years, retiring in 2019. For 3 decades, she was at the forefront of developing Manitoba's film and music industries into international success stories. Carole was diagnosed with stage 3 NSCLC in September 2020 with MET14 exon skipping biomarker. This is her 3rd year co-chairing the CancerCare Foundation Guardian Angel Planning Committee. Carole's focused on advocating and increasing awareness to know your biomarker, clinical trials, and that precision oncology is the gold standard for cancer treatment and should be a priority. Focus federally and provincially needs to be on early lung cancer detection, clinical trials, precision oncology, research, and funding. This should be a national priority as lung cancer kills more than prostate, breast, and colon cancer combined. In retirement, Carole enjoys traveling with her husband, spending time at the family cottage, and having fun with family and friends. Welcome, Carole.
Thank you. I'm sure you're all very tired and want to go home soon. I want to thank everybody for their presentations tonight. Really informative, hopeful. Looking at the research that's coming down, it's fantastic. And I want to thank Alyson and Corie for sharing your stories tonight. The Lung Cancer Manitoba group is a fantastic group of people, and it gives us all lots of hope, and we have fun too, so it's even better. So my story, I was, retired in 2019, all great, went on a great trip, we come home right in the middle of frickin' COVID. And,
September 2020, I kind of had the same symptoms as Corie. I had this weird sensation in my chest in the spring. I had x-rays, I had a whole heart workup, said that was nothing, so I kind of ignored it, settled down, kind of came back in the summer. Anyways, I ended up having another x-ray and it showed. So there was nothing 2 or 3 months earlier, and all of a sudden now is the light it's lit up on my lung and the lymph nodes. And it felt like a cliche, you know, you work all your life and you have retire and you get this whole plans and all this, and it's like you get this crappy diagnosis. It's like, oh my God. But anyways, it is what it is. I had the biopsy, I had PET scans, etc. And the diagnosis was lung cancer, stage 3C. We also had our house tested for radon, and our numbers are also through the roof. We were obviously very shocked. I still remember actually my doctor calling me. Everything happened on a Friday. It's uncanny, but everything happened on a Friday. I get and you know, the results on a Friday, but you have to wait till the next week for more tests. Like, it was just bizarre, always on a Friday. My husband was in the garage, went out to the garage, and I said, whoop, I'm in a little bit of trouble. So we both had a little bit of a cry, and it was like, okay, I'm that type A personality. So it's like, all right, what's the plan? You know, I need a plan, and that's how I will deal with this. So my pathology was tested for a variety of biomarkers, which came back inconclusive. So my oncologist, Dr. Banerjee, who's here tonight, was very suspicious I had the MET biomarker mutation, and encouraged us to have my pathology sent to the US Foundation to be tested. We were fortunate we were able to pay out of pocket. It was about $3,500, but it was worth it, and because it did come back conclusive for the MET14 exon skipping mutation. So now we know what we're dealing with as a mutation. So I went through 12 weeks of 2 immunotherapy drug and 2 chemo drugs. But at the end of it, the CT scan showed that even though it was effective on my lung, the lymph node, in fact, had grown. So now, you know, I start doing research, finding out, and you start learning more things. And I do have a low PD-L1 number. So that's why the immunotherapy does not work for me, which sucked. You know, would have been great if it had worked, because I only got 12 weeks on that. And I was a little bit naive at that time because, you know, your first time going through all of this. So, okay, this not working, what's next? And I truly feel that I had guardian angels, because right when I needed it, Dr. Banerjee was opening a clinical trial here for MET14 exon skipping. You saw that sheet that showed all the biomarkers. It could have been ROS, could have been EGFR, but it was MET14 exon skipping. I mean, how lucky was I? And if I hadn't had my pathology sent to the US Foundation and confirmed it was MET, I wouldn't have been a candidate for this trial. So everything was kind of lined up for me. I had to go through a bunch of testing, obviously, to make sure I was a candidate for the trial, and I passed. And that was like a very happy day, I'll tell you, when I was told, hey, you're starting that clinical trial. So I had 3 years on this trial, which was unbelievable. You know, it was a pill I take. We've traveled. It really hasn't affected my life that much. So everything was going great. But then in October, I had one of the lung tumors had grown. So I did have stereotactic radiation, 8 treatments, which shrunk it down. So that was good. And then my scans in February show progression to my liver and pancreas. Lung is stable, but now it's going somewhere else. It's like, freaking cancer is so sneaky. It finds a way around these drugs. So it's like, okay, now what do we do? And so, and actually, after 6 weeks on the clinical trial drug, everything shrunk by about 70%. So targeted therapies work. So now I need a new precision oncology drug. And the drug I've been on is an inhibitor So as my oncologist said, doesn't make sense to go on another inhibitor because it's not working. I'm staying on the clinical trial drug while this is getting sorted out. But we want to try a drug that's an antibody next. So Dr. Banerjee is pursuing access to an antibody drug from the US. It's promising, but it's a very lengthy process and I have no other options. So my fingers and toes are certainly crossed. But I find it very disturbing that Health Canada and CADF, they have not approved that I'm aware of any precision therapy drug from my biomarker in the country. So there's no drug that they can write a prescription for me because they're just not available. And this forces the oncologists to go through these ridiculous hoops to get access to these targeted therapies that have been used in the US for years, but they're not in Canada. It adds anxiety to the patients and their families. And recently, CADF rejected another MET drug, capmatinib, but NIS in Quebec approved it. This is Canada. So now we have a drug that's been approved for Quebec, but nobody else in Canada can access it. That's ridiculous. So I'm gonna get on that one. That really bugs me. So I just wonder, like, how is that allowed? Like, if it's approved in Canada, it's approved in Canada. So but anyways, it's another inhibitor, so it wouldn't be an option for me, but it's the principle of the thing. But I want to talk about precision oncology is the gold standard for cancer treatment, using companion tests and biomarkers to determine the right drug for the right patient at the right time. I'm an example of this. I had 3 years that I would not have had without this precision oncology drug. And now I need another one. I want to know, is precision oncology a priority for the province? There was a recent precision oncology conference in Western Canada. Manitoba had nobody from Manitoba Health attend. Saskatchewan had their people. Alberta had their people. Manitoba had nobody there from Manitoba Health. So that's concerned. Are clinical trials a priority for the province? Clinical trials save lives, save mine, and provide access to new free therapies and provide, like, the pharmaceutical company pays for that trial drug. So that means that the province not paying it out of the provincial formulary. So for 3 years, I've been on a trial drug that they've saved, not paying for my chemo or immunotherapy. I feel that trials are looked at as a burden on the health system rather than an opportunity to innovate and reinvest in the system. If I didn't have the clinical trial drug, the province would have been paying for my chemo treatments. So there was savings over those 3 years. They should be returned to the clinical trials unit for further research, diagnostics, lab expansion, etc. It just makes sense. And also I find out that when each cancer, like if there's 3 cancer centers that are each launching the same clinical trial, they each pay the same legal, same administrative costs. It's ridiculous. What a waste of time and money. There should be collaboration between the centers where they're not all doing the same work and paying the same money for the same thing. That's just a waste of money. It should be more collaborative. Lung cancer kills more people each year than breast, colon, prostate combined, but receives the least amount of research funding and attention. I really believe that the stigma associated with that it's only smokers that get lung cancer has really adversely affected research and research funding. And I'm really concerned when I saw those MAID stats, as we all were in this front row. It's like the highest number of people accessing MAID are lung cancer patients. Well, if this doesn't make it clear that lung cancer research, treatment, etc., should be a priority, I don't know what is. To me, this is a crisis. Like when you see those numbers, like So we need way more attention on this than what's currently being done. 50% of new lung cancer diagnoses in the world are women who never smoked. Most of the women and the patients on the lung cancer group are non-smokers. Cigarette smoking is decreasing, but lung cancer is up. So clearly there's lots of research that needs to be done there. So now I wait anxiously to see if I will get this new antibody treatment. I always stay positive. I'm grateful and hopeful, living my life. When I was first diagnosed, I didn't want any of the stats. To me, I was like, stats are for baseball. I don't want them. I'll create my own stats. I'm gonna be different. But you know what? Living my life, traveling, spending time with the family and our friends, co-chairing the Guardian Angel Committee, Planning Committee, which is a big fundraiser for women and cancer here in Manitoba, is to give back. And I'm gonna be here for a long time. I'm gonna watch my granddaughters graduate from university. I'm gonna attend their weddings if they marry. I just remain hopeful and positive person. Have incredible support with my husband, my kids, my friends. I have a huge group of friends that are amazing. And I just want everybody to be hopeful. Here I am almost 4 years later, still kicking. So stay hopeful, and I wish you all the best. Thank you so much. Oh, thank you.
So, yeah, we're quite over on time, so I just want to thank everybody once again for coming. Thank you to CancerCare Manitoba and the CancerCare Manitoba Foundation for helping to put this event on. You can see that for more Lung Cancer Canada, you've had brochures that are around. We provide help with navigation support groups, one-on-one social work, although here in Manitoba, you have good support. Not all provinces are the same though. And I just want to thank you all for coming, attending those online. And I hope you were informed and inspired. I certainly was. So thank you all.